OPA workshop entitled Explain Pain, Strategies for Helping Patients with Pain by Dr. Ryan Dix, PsyD. I'm Linda Starbird, and I'm an OPA board member and liaison from the Central Oregon Association of Psychologists. So I'll introduce Dr. Dix, and then we'll go through some housekeeping items, and then we'll start. Dr. Ryan Dix is a licensed psychologist who serves as the clinical manager for the No One Cares Alone umbrella of programs serving Providence caregivers. Since 2013, Dr. Dix has served in several roles for Providence, including as the clinic manager for Providence Medical Group's Oregon Adult and Senior Psychiatry Clinics, and behavioral health manager of primary care medical specialties for Providence Medical Group in Oregon and in Southwest Washington. Prior to that, Dr. Dix spent 5 years as a behavioral health provider with Providence at their Northeast Clinic, where he also worked as a behavioral medicine faculty for internal medicine residency. Throughout this work, he has worked with a large number of patients with a variety of pain syndromes. He's been on several level advisory implementation groups for pain policy, developed group curriculums for patients with pain, and presented at a number of venues on the topic of pain. Dr. Dix also currently serves as the legislative committee chair for OPA and has served in several roles on that board, as well as being the liaison from OPA to the Oregon Board of Psychology. So thank you, Dr. Dix. Let me just go over some housekeeping and we'll get started. So your microphones and videos are muted for the entire webinar. Please keep them that way. To ask a question, just put it in the chat section and we will ask questions of Dr. Dix on your behalf. Please feel free to submit your questions at any time, but roughly at the top of the hour, we will break. And before the break, I'll ask Dr. Dix your questions as the moderator. We'll try to get to as many as possible, but you know, we have 4 hours today, so we're a little limited on time. The webinar counts as 4 CE units. We're recording the presentation and we'll be making it available at a later date. We plan to circulate the presentation materials, details on how to receive CE credit, and our contact information via email after the webinar. We're using Zoom as our virtual meeting platform. A CE verification code will be provided at the end of the presentation, along with a link required for the CE credit. The OPA staff will be cross-referencing the survey evaluation forms to the attendance list after we complete the webinar. One of the questions on the survey will be asking for that verification code, so be sure you write it down. We'll give attendees 1 week to complete the survey, and once OPA staff has cross-referenced the list, CEs will be sent out within 3 to 4 weeks after the event. And so with that, we will invite Dr. Dix to begin the webinar.
Hey, good morning, everyone. Let me share my screen here. Linda, since you're the only one that's not muted, I think, are you seeing a large PowerPoint presentation?
Yes.
Excellent. And if I change to presenter view?
Yes.
Does that continue to show the large screen, or does that show my slide as well?
Now we're on the large screen only.
Large screen only, fantastic. All right. Well, good morning, everyone. Thank you, Linda, for the introduction. I know several of the names that I saw kind of flashing through. So I wish I could see your faces and actually talk to you in a conference room this morning. As we go ahead and get started this morning, we're gonna talk through one of the models that is utilized within Providence, and then a model that I really found quite beneficial in working with patients. As Linda discussed, my background is primarily in integrated primary care. And so a number of the patients that we receive referrals for in that setting had chronic pain. And so it's an area that I have a lot of experience in, but also spent a lot of time educating myself around kind of different models. And so there are certainly other models that exist in terms of understanding pain and working with patients with pain. This is just one that I have found to be quite effective, particularly in a primary care environment, but there's no reason why it couldn't be helpful in a private practice environment as well. So this morning's objectives, we're going to spend a good chunk of time understanding the explained pain conceptualization of the pain experience. And the reasoning for that is the way that explained pain talks about pain, in my experience, has been quite helpful for patients, both in terms of helping change the narrative for them, but also giving them really practical tools to be able to utilize. And so I want to make sure that people leave here with a really good understanding of how the authors of that book and a few other books understand the pain experience and be able to explain that to your patients as part of that process. As part of that, we're also going to spend a decent amount of time talking through a number of the tools that they highlight in their text, as well as kind of modifications or ways that I have adapted those over the years to talk with patients and really get them engaged with a more kind of functional relationship with the pain experience that they have. And as part of that, in my experience, having worked with really thousands of patients with persistent pain over the years, developing skills to motivate patients to engage in those lifestyle improvements that are such an important part, both of the treatment themselves, but of course, helping a patient have a fulfilling life. And so we'll spend a good chunk of time talking through some of those pieces as well. More practically speaking, as Linda mentioned, we'll try and take breaks at the top of every hour, both for some questions, but also hopefully for a coffee or a additional breakfast break. But we're going to start with a little bit of background. And for a portion of the background, I'm hoping it's a review for a number of you, but there will be just some of the latest kind of statistics and pieces as far as the background is concerned. We'll talk a little bit through the old model, as I like to think about it, of working with pain. We'll then talk about the new paradigm, or again, the paradigm that I've found to be quite helpful. And as part of that, we'll really talk through some practical tools and strategies. Now, I realize your audios are turned off, but I believe the chat function is still turned on. And for those of you that have seen me talk before, I really prefer to be much more interactive than this webinar platform really allows. But what I'd like to at least have kind of dropped in the chat, and Linda, I don't know if you could just kind of read off. But what are some of the challenges that you all have had in working with patients with pain? And I'll just give folks a couple of minutes to drop some of those in the chat. And then Linda, as they come through, if you wouldn't mind reading off some of those for me.
And so from Sean Davis, we have patients who have increased depression and hopelessness. And from Irina, patients' hopelessness. From Annalise, oops, they're faster than I can read.
If I pull up the chat on the side, can you all see the chat? I'm never quite sure what I'm showing versus not showing.
On our screen, the chat is right smack in the middle. It's usually over to the side, but
I mean, if I have it up on my screen, does it impact the slides on your view?
No, it will not.
not right now. Mm-mm.
I can go ahead and take over reading them then.
Fantastic. Okay.
Yeah, so Irina, patient's hopelessness, Annalise, fusion of medication as the only path to management, Janet, discouragement, distress, Arthur putting in reliance on narcotic pain medication, Alexandra following through with homework given. Patrick, I experienced many patients having something akin to cycles of recovery, relapse around pain and self-efficacy. Scott, refractory migraine pain. Reagan, parents not knowing when to allow their children experiencing pain to stay home from school. Another one for helplessness, insomnia as a big portion of that. Lauren, everyone is frustrated. Patients with hopelessness, providers trying multiple modalities to support patient with little perceived relief. So really just a number of challenges here. And I know, knowing several of the people on this, I know that some of you are in private practice and some of you are in group practice and some of you are in an integrated primary care environment. And so I'm imagining any of you who have, again, interacted with patients with pain, which chances are if you've seen more than 5 people, you will have interacted with somebody with pain. There's a lot of shared experience across these environments. Just the last couple here, Stephanie, my clients come into therapy for help with pain already defensive and angry because they feel referral to therapy is invalidating their physical experience. Insomnia, social withdrawal, absolutely. And again, having worked in primary care the majority of my life, so many of these pieces ring true. For those of you that are familiar, and Stephanie had a similar kind of comment here, we get the majority of our referrals through the primary care providers. And in that environment, patients are referred, and as Stephanie kind of highlights, come in with really a number of beliefs about what that means for them. And the conversation around defensiveness and being angry is one that I interacted with really regularly, and is part of what motivated me really early on to seek additional education and training in working with patients with persistent pain. I don't know about you all, but when I went to graduate school, I didn't actually receive very much training on pain. I'm imagining the majority of you are probably in a similar camp. Again, I can't see your heads affirming or not, but based on my experience and having been involved in training over the years, a number of other individuals didn't really have that background either. And so really that the frustrated patient coming to me was one of the large motivators I had for getting additional training in this environment. The other, and I'll round back to this a little bit later on, but the other reason for me in moving this forward is really early on in my career. Again, this was in a rural hospital environment, but I still did a lot of integrated primary care. I had a number of patients referred to me with persistent pain. And I was a new psychologist, but I considered myself an adequate one. But there were a number of patients, especially those who had persistent pain, who would not come back to their second appointment. And that was abnormal as it compared to the other patients that I had. And so I spent a decent amount of reflecting on that. And so I'll come back to that when we start talking about the tools and strategies, but that was at least one of the motivators for me to move forward with this. And I think I cracked the case as to why that was as I moved later into my career. But I'm hoping if that's an experience that any of you have had, that this can be part of helping you with those pieces. Thank you everyone for commenting on these parts. particularly just highlighting the challenges that you all have. Hopefully in leaving today, you'll leave with some tools that will feel beneficial in terms of addressing some of these pieces. I just threw in a couple of kind of comics as part of this process to keep you awake and that kind of thing. It's early Friday morning. So this is both a reference to the pain scale that is oftentimes referenced, or at least in my world used to be referenced in terms of rating of pain. And just kind of acknowledges some of the challenges that we're all participating in as part of this process. So the other audience participation piece for just to get us started this morning is what motivated you all to take this course? I know it wasn't to listen to me on an early Friday morning.
Are you going to read these, Ryan, or do you want me to read them?
I'll go for it. Thanks,
Okay.
Reagan. Reagan was going to give me a laughter emoji, but I guess they're turned off. It was a requirement. Okay, I'll take that. Janet, help with my clients, gain more tools to talk to patients and their parents about their persistent pain. Another required CEU, increasing competence and skill. I also did not receive a lot of graduate school training. License requirement, it's been a while for me since focusing on the topic, required CE, good timing. I will be receiving patient referrals mostly relating to pain, and it's very much related to my dissertation. Excellent. Saw dope sick, and that really piqued my curiosity. Yeah, absolutely, curiosity. Yeah, and learn to work with all the frustrations noted above. Excellent. Thank you, everyone, for and Stephanie, they're just dropping in again, kind of one of the more common factors in client complaints. And the part of me asking what motivated you all is an opportunity for you all to tell me what brought you here today. And I hope to spend the next couple of slides reinforcing why you came here today and the importance of this work. In reflecting on my career up to this point, working with patients, far and above, the majority of the work that I did was with patients with persistent pain. And when we start to review some of the data around that, that shouldn't be surprising. And it really should be, I would imagine, a large proportion of patients that you work with as well, albeit that may not be kind of their primary referral reason, or may not be something that has been brought up. But just given the statistics, very highly likely that that is your highest group of patients as well. So let's go to the next slide here. All right, so we're going to spend a little bit of time just talking through some data, just to make sure we're all starting with this from the same place, but just to provide some updates as well. So broadly speaking, there's about 1.5 billion people worldwide who suffer from persistent pain. And I guess one more audience participation part. Who wants to take a pass at defining chronic pain or persistent pain? Or who can Google the fastest and drop it in there? It's maybe the other question.
Persistent pain.
Chronic lasts longer than 6 months. Okay. Anything that anybody would argue with that or add to that? All right, well, it sounds like the group's going to go with that. So, yeah, chronic pain generally after acute injury healing. Yeah, so there was an injury that occurred, one that lasts longer, pain that lasts longer than expected after an illness or injury. So it varies a little bit in terms of the definitions that you see out there. Most will say pain that lasts after 6 months. There were some that will kind of identify the 6-month marker. In my mind, the timeline is less important, and is so I typically use a definition that the Cleveland Clinic has put out, partly because it highlights so many of the important parts. So their definition is chronic pain is an experience that can interfere with your daily activities, such as working, having a social life, and taking care of yourself or others. It can lead to depression, anxiety, and trouble sleeping, which can make your pain worse. This response creates a cycle that's difficult to break. And in my experience, the time that a person has had it, again, it hasn't necessarily been the reason they come and talk to me about it. They come and talk to me about it because of the impact that it's had on them, whether, as many of you noted, because of trouble with sleep, trouble with depression, trouble with anxiety, potentially having medications that they rely upon to be part of that process, and feeling like a referral. As I heard many times, I'm coming to see you so that the doctor will continue to prescribe my fill in the blank pain medication. And so what all of you highlighted is really just the impact that persistent pain has on the person who's experiencing it. Now, that's not to say that timelines and those pieces don't matter. It's just that by and large, patients are coming because of the impact that is having on their lives or their ability to function, and are looking to us, in some instances, not necessarily fully voluntarily, but come to us for help in some form or fashion. So again, roughly 1.5 billion worldwide. There's a 3 to 4.5%, excuse me, of the global population suffers from neuropathic pain, with an incidence that increases with age. Looking more specifically at the U.S., in 2016, which is recent pieces of data, there was about 70 million adult Americans that would be 12 and over. In what that kind of data has shown, and it kind of varies. The Institute of Medicine had a report back in 2011 that estimated about 100 million adults. So suffice it to say, it's a lot of adults who are experiencing pain as part of that experience. And again, it's a conservative estimate. It looks like there's a few individuals here on the chat today who work with children and families, and so this estimate is quite conservative because it did not include just kind of pain more broadly and didn't include children as part of the CDC's estimate. And to talk just briefly about the kind of economic portion, and I'll return to this in a second. Health economists, this one came out of the Institute of Medicine report from, it was 2011, estimated at somewhere around 560 to 635 billion annually. That would be about 2,000 for every person living in the US. Again, we'll circle back to that just real briefly as it pertains to just the economic costs. But to spend a little bit of time talking about where does chronic pain kind of exist in the relative disease burden of individuals that we might interact with. So this came from a presentation or an article out of the New England Journal, but the statistics were a little bit dated, so I have updated them based on the CDC data and then the National Cancer Institute. But you'll see that when I said that chances are you all have seen and regularly see patients with persistent pain, even though they may not present with that specifically. In looking at this data, again, you'll see that when you combine the kind of 4 next largest disease burdens, it's about equivalent to that, slightly less, but it's by far and above the largest disease burden that we'll interact with. Sorry, my slides froze there for a second. So we're not going to spend a lot of time on the cost context, but just to speak to it really briefly, Halloween's coming soon. It's my mom's favorite holiday. I have 2 kiddos who love to dress up and to trick or treat. So as far as little cost context, in 2019, we spent in the U.S. about $8.8 billion on Halloween. 490 million of that was on costumes. That was just for our pets. The total kind of cost of cardiovascular disease, according to the CDC, is 219 billion. National Cancer Institute estimates cancer care to be around 200 billion as well. And then diabetes is around 327 billion. So again, when you look at the persistent pain estimate, anywhere between 500 billion, 650 billion, you start looking at those other disease burdens, and you quickly kind of tally up to what really the cost of persistent pain is. And so in addition to just the sheer prevalence of persistent pain, for some, kind of the impact on our broader healthcare system and the costs, being active participants in a what I would argue a more effective way to address persistent pain has value kind of all around. And so for me, I really enjoy working with patients with persistent pain when I was still seeing patients. And it's something that I hope, again, for those that may have just come to this because it's a requirement, you too will leave here with a little bit more excitement to working with some of these patients with pain. Again, for lots of really good reasons to have this information. These are not my pets. Nothing against people who dress up their pets, but I don't have pets with costumes. So I found these ones on Google. So specific to other mental health conditions, persistent pain, as many of you highlighted when we talked about kind of the challenges with pain, highlighted insomnia, social withdrawal, hopelessness, really fusion with that as part of their identity, decreased movement, depression, kind of all of these different pieces. And so we'll spend a little bit of time talking through what other mental health conditions exist as it pertains to prevalence of persistent pain. So starting here, those with chronic pain are 4 times more likely to have depression or anxiety than those who are pain-free. So looking at the prevalence of persistent pain and thinking about how that impacts depression, simply looking at across your panel, the number of patients who have depression, I would imagine, is a large percentage of that. And so the comorbid aspects of persistent pain are going to be a significantly high portion of those individuals. In looking at the reverse of the prior statistics, 75% of patients with depression, again, this is a primary care setting, but those kind of data oftentimes transfer. as it pertains to depression anyways, complain of pain-related symptoms. So in thinking about your panel, again, of those patients with depression, 75% of those are likely to experience or complain of some type of pain-related symptom. Additionally, increased pain intensity predicts increased severity of depressive symptoms and worsening quality of life. I'm curious for those who, as part of your standard intake, or for those in primary care, your kind of first appointment, ask about pain experience as part of that. I know we can't do like a thumbs up or anything, but just maybe a yes or no in the chat. Yeah, so kind of napkin math looks about maybe half of you incorporate it. Now, how many of you as part of your intake are assessing for depression? Thanks, Kathy. Yeah, that wasn't necessarily a real question, but is really only I asked to kind of make a point. In just the sheer kind of prevalence of pain experience, and some of these statistics, it's something that hopefully when you all leave here today will be something that you at minimum start to incorporate into your intake assessment. It doesn't need to be the level that we'll talk through in doing a pain history, but it's something that not only impacts the patient's experience as it pertains to just all the things they do throughout the day, but it's going to impact your efficacy in terms of treating things like depression and anxiety. And in many instances, if not done at least somewhat together, you will oftentimes see a lack of improvement in some of these other symptoms. So another reason to keep it in mind is the next statistic here, which is patients with depression and chronic pain, are more likely to commit suicide than patients with depression or pain alone, or those that have pain without depression. And so it's really that comorbid existence of depression and persistent pain. You'll hear me use the words persistent pain, and a lot of the literature utilizes chronic pain. Persistent pain, based on the model itself, in my experience, has less of a kind of lifetime, patients experience it with less of a lifetime, I'm going to have it forever kind of way, and is a term that I have found to be more helpful than chronic pain. But again, in the literature, you'll see that used quite a bit here, but just in case you're wondering why I'm utilizing persistent pain instead. And then similar to depression, bidirectional relationships exist between chronic pain and anxiety. It's particularly evident in individuals with migraine headaches. And you will see that there are bidirectional relationships with substance use disorders and other mental health conditions as well. So the existence of a pain experience is going to impact almost anything that the patient brings to you as it pertains to a mental health condition. And so again, for those that don't incorporate it, I would encourage you to at least include a question or two around the patient's experience with pain as part of your intake evaluation. Now, with chronic pain and substance use, I'm fairly certain you would have to have been under a large, heavy spherical object to not be aware of the opiate pandemic as part of this. And so some of these statistics, again, I'm imagining are things that you all are familiar with, but there are some, what I would argue are improvements that are starting to be seen, particularly around things like opiate use disorders. And so wanted to highlight those because I think that we're all part of that work and part of that improvement in offering alternatives to opiates as part of treating chronic pain. But we'll start with some of the harder statistics in my mind, which is that we are still losing a lot of people to drug overdose, and 2 out of 3 drug overdoses in 2018 involved an opioid. And so it remains a devastating kind of epidemic of its own. You'll see that in the roughly last 2 decades, 750,000 people have died from drug overdoses. In 2019, 10 million age 12 or older misused opioids in the past year. Specifically, a good portion of those were misused pain prescriptions. A much smaller portion used heroin. And so prescriptions remain the primary source for opiates when it comes to misuse. On a more positive kind of aspect of that, we are seeing significant improvements when it comes to things like medication-assisted recovery or medication-supported recovery. Just in the years noted here, and a lot of this comes from the National Institute on Drug Abuse, that we've seen a 142% increase from 2016 to 2018. Now, unfortunately, that still is nowhere near meeting the need, but it is a marked increase as part of a number of initiatives that have been done both nationally and then regionally as it pertains to getting more people into medication-supported recovery. Naloxone, as I'm sure most of you, if not all of you, are aware, is a medication designed to reverse opioid overdose. And the number of prescriptions for those have doubled from 2017 to 2018, according to the national survey that was last available. So we are seeing a number of still very hard statistics in this space, and we're starting to see a few areas of hope as it pertains to getting patients more help when they have gone with what has been the historical kind of treatment for persistent pain, which was opiates. And oftentimes that kind of progresses. So just as a couple more slides on the prescription component around overdoses, just again, I know that each of you have different patient populations that you work with. And so just to highlight a couple of statistics for just specific populations. So more men than women die of overdose from prescription painkillers. Middle-aged adults have the highest overdose rates as part of prescription pain. I'm from a rural place and initially practiced in a rural place. And so for those of you that might be in rural places as well, those in rural counties are about twice as likely to overdose on painkillers as those in the city. Whites and American Indian or Alaska Natives are more likely to overdose on prescription painkillers. And about 1 in 10 American Indian or Alaska Natives aged 12 or older use prescription painkillers for non-medical reasons in the past year. And you'll see statistics, 1 in 20 for whites and 1 in 30 for blacks, according to American Academy of Pain Medicine from 2015. which is the last data they had available as part of these special populations or specific populations. Even though we have made really significant progress with prescription pain approaches, we still are seeing a significant amount of death attributable to that. So you'll see that roughly 16,000 people in the US in 2020 died of overdose with prescription painkillers. That's 4 times what we saw in 1999. This was admittedly a staggering statistic for me, even somebody who has worked a lot in this space. More than 4 out of 5 pharmacy prescriptions are opioids, according to the CDC. It still strikes me there. That being said, opioid prescriptions peaked, according to some of the same sources, in 2012 and have been steadily falling since then. If you've not had an opportunity to look at some of the charts and things like that the CDC has put together, there's some really good graphics that show some of these statistics that I'm highlighting here for you. Non-medical use also costs about 73 billion in direct healthcare costs. So our involvement with pain is so multifaceted, and one of the main ways is, again, providing an alternative and being part of helping patients either identify some of their behaviors that might be contributing or might be aspects of a use disorder or these other parts, and providing some really practical tools and tips, and of course just assessment around being able to help patients get the care that they need as part of impacting a number of these statistics. So the old model, as I refer to it, is, we believe for a long time, and again, we could spend days on various kind of aspects around the opiate crisis and so forth. But again, I know that many of you are familiar with all those pieces. But basically, for a number of reasons, we felt, the kind of broader medical community felt that opiates should help. That was kind of the old model that, or what I describe as the old model, that we should have seen, we see benefit from opiates, and those should be helpful. But for all the reasons we've highlighted and a few others, we know that that's not in fact true. And just here's a few statistics to really further that point. This study identified opiate use significantly associated with decreased physical activities, level of improvement, employment, self-rated health, self-rated quality of life, and increased self-reported severe pain. So what you oftentimes hear, and again, not to say that there aren't some who do see benefit, but when you start looking at populations, you see that a number of the things that they are supposed to have helped with, we don't see that. We don't actually see benefits from those. Longer duration of opioid use associated with increased all of the things we've talked about: depression, anxiety, PTSD, substance abuse, and then escalating opioid use. And then there was a Cochrane review in 2013 that many of you may remember kind of coming out that showed no improvement in functioning with opiates. And there's been a number of other studies since. And so again, not to belabor that point, but there are still, based on the statistics, still a number of people who, from a patient experience, believe in the benefits that they are getting as part of utilizing these medications. And I certainly have had some that did seem to function fine with them. And so, you know, with all statistics, there's always individual cases. But by and large, and when you look across populations, we just don't see the benefits. Thank you, Linda. Yeah, and we are coming close to the end of the hour. And so questions that we have, go ahead and drop those in. And then this is just kind of a natural breaking point as well. So hopefully I haven't bored you too much with just some of the background. But in case I have, I offer you hopefully a comic to wake you up back. And really just to, it's not meant to be derogatory towards doctors or anyone. It's just, it's meant to be, you know, I had a number of patients with pain experiences who felt like this, who felt like the doctors, you know, as they use kind of broadly, you know, didn't know what they were doing or just kept experimenting on their pain experience. And I had patients upwards of kind of 30 abdominal CTs, or who have had multiple exploratory surgeries for various pain syndromes, in an attempt to either find a quote unquote cause or to find a solution. And so again, I include this comic partly for humorous purposes, but really it captures well how a number of patients that I interacted with felt as part of their interactions with the medical environment. So with that, I will pause for questions. Or comments. Can you please say more about the statistics saying opioid use actually results in increased pain? Just go back to that so we can all reference it together. So Reagan, I think you're talking about, the second bullet, or excuse me, third bullet point there that talks about escalating opioid use. Is that correct? Is that the one you're referencing? Oh, okay, but maybe both. Okay. Yeah, and that's actually a fantastic lead in to what we'll spend the remainder of our, well, not the remainder, but a portion of our time going forward to really help you all. But in my mind, I'm really going to be talking through the lens of how I would talk with patients about how they came to be where they were at. And so in talking through that model, hopefully it'll become clear as to how a person can experience more pain despite oftentimes escalating opioid doses. So teaser, we'll get to that a little bit later on. Really to both points, both the increased experience of pain, but also the escalating opioid use that you will see as part of that experience. And then Kathy just highlights clearly pain is not pain. Well, pain is all sorts of things. It's a complicated thing. And so hopefully people will leave here today with a good framework, and at least in terms of how to talk with patients about it. So Jeff, I'm not sure if this was your intention, but I'm going to suggest we take until 9 and give you a chance to refill your coffee, grab some breakfast if you haven't, and we'll start back up here in 8 minutes or so with the next section.
Hi, Ryan. Uh-oh.
Uh-oh.
So we're back.
Recording started. That makes it official.
Mhm.
All right. Well, I might give folks just 1 minute to trickle back in.
Yeah. This is great information.
Well, thank you. I hope it's helpful.
Yeah. I don't, I mean, I don't have a specialty in this area, but I struggle with, you know, people that I see that do have some chronic pain. They're maybe getting treatment and maybe not, or maybe they've just given up. But I struggle to know where to direct them for, I don't know, evaluation, treatment, anything.
Mhm. Well, hopefully when you're done here today, they can get treatment with you.
Oh, dear. Uh,
All right. Well, we'll go ahead and get started again.
Great.
So as we spent the last 35 minutes or whatever, just talking through both what we understand about the prevalence of persistent pain, as well as the comorbid conditions that you'll be interacting with or have interacted with as it pertains to patients with persistent pain, and vice versa. That persistent pain is such a common experience that incorporating that as part of your initial evaluation is such an imperative starting point from my perspective. But now that we've set a little bit of that groundwork, we're gonna talk through kind of where do we go from here? What do we do in terms of starting to work with patients with persistent pain? And it looks like, just in the chat, that there's a few, at least a few, who also, I think I saw one dissertation on pain. I know a few of the names of people who I absolutely know work with patients with persistent pain. And so I look forward to hearing from all of you as well as part of this process to see if there's things that you'd like to add. So even though we're kind of holding questions, by all means, I do have the chat up here on the side. And so please do. I'm sadly really used to virtual platforms, as I know we all are at this point. So feel free to kind of drop comments and stuff as we go through. So I left you with that slide, again, highlighting the patient's experience that I've had, that they come to me, and I would imagine, and it sounds like come to all of you, with really a mixture of perspectives around persistent pain, around how the medical environment has treated them, how their friends and family treat them as part of that process, and of course their relationship with themselves, their own body. I'm imagining, just again, statistically, there are probably some people on this call who have experienced persistent pain, or perhaps still do. And so people come with all those different parts to these appointments. And so in moving forward, how I approached patients with pain in accordance with this model. Again, there are many others. And so for those of you that have others that you enjoy, that's great as well. This is just one alternative that I found to be quite effective. Hopefully there's not a lot of convincing that's necessary for this first bullet point, given the audience, but starting with empathy, and I'll talk a little bit more about that here in a second. We'll talk through a pain history, and for those of you that have experience with pain histories, it likely won't be, there'll be aspects that are similar, but there'll be parts that hopefully are slightly different. We'll talk through the new model, and then we'll end with behavioral strategies. And so this is really where we'll spend the remainder of our time with one another. I'll still plan to take breaks at the top of the hour. So we'll hopefully kind of stagger our time in a meaningful way for everyone. Yeah, thanks for the comment that was just dropped too. Opioids still have their place. and that's absolutely true. And I hope they don't overregulate. They have worked well for me post-surgery. Yeah, and I think that's something that that I've seen with lots of patients as well. There were a number who opioids had helped in lots of different circumstances. So yeah, not to say again, kind of across the board, that for every single person ever, as we know, that doesn't apply to anything. But there are definitely there are instances where it has helped quite a bit. And I've had a number of patients who it really did improve their functioning as part of that process. So thanks for offering that, just your own personal experience as well. So the first step in this model, as I mentioned, is empathy. Again, I hope that doesn't require really any convincing for this group, but just to circle back to the story that I started to share a little bit earlier. When I was early on in my career, again in a primary care environment primarily, but I had a number of patients who were referred to me for persistent pain. And I, again, left graduate school with very little, at least kind of formal training in that. I had done practicum and things like that, but still didn't have a lot of formal training in working with patients with persistent pain. And so had a number of patients who, as I mentioned earlier, didn't come back to their second appointment. And that was a different experience, again, than a number of the patients that I saw who would come back and we'd continue to work on things. And what I kind of learned over a period of just reflection and talking to other people and going to trainings and things like that is I was not spending significant enough time with this step. And in my experience, and I'd be curious for others, again, who have done a lot of work in this space, if you'd be willing to comment as well, that patients with persistent pain, again, not to kind of say everyone's the same, but by and large, the amount of empathy and relationship building is significant as part of the really first appointment. And I think a lot of that comes from, again, what they have experienced up to that point. In many instances has been years, in some instances decades of experiencing significant pain. And for some, that has resulted in a loss of kind of every part of themselves. I had patients who had lost relationships, lost work, lost homes, lost housing, had really lost all of really who they thought of themselves as prior to that. And on top of that, in many instances with pain, a number of patients didn't have an outwardly obvious injury. And so as we'll get into, pain is very much an individual experience, but many patients experienced both their friends, family, providers questioning that pain experience in a number of different ways, and in many instances, very unhelpful ways for the patient in terms of invalidating what they knew to be true about their experience. And so a few of you who have heard me talk about this have heard me say this before, but I really took on kind of a barometer in my own mind of working with patients with pain. That was, I continued to do reflective listening until they were no longer verbally convincing me of their pain experience. And that sometimes would take an entire appointment where they really spent time talking through what they had experienced up to that point. And once I started making that shift, most patients, again, not all, but most would come back to their second and third and fourth appointment. But it really was focusing in on letting them know that I believed them, that I believe that that has been your experience, that I believe that that is how you experience the pain that you experience. And again, as part of that, they would oftentimes discuss the number of interactions they had with a significant other or a friend or a provider who very much invalidated their experience. And it's not always done in a really obvious way either, but something as simple as getting some imaging back and saying, oh, everything looks normal. When an individual is having back pain or something like that, can really be experienced as an invalidating piece of feedback. And so in working with these patients, that is where I spend as much of the first, and in some instances second, and if needed, the third and fourth, around validating what their experience has been up to that point. And if at any point in the subsequent appointments, as we started talking about some of these other tools, they would return to that, I would also return to that. And in doing so, again, have found that a number of the patients that I was working with would stay with all of the work that we were doing. But maybe this isn't a realization to everyone else, but for me it was just really needing to spend even significantly more time than others. And for those of you that are aware, integrated primary care is oftentimes done in 20-minute appointments. So one of the things that we are trained to do is to be able to create a relationship in a very brief kind of way. And in these instances, it always took significantly more time. And then for me, again, I think it was just reflective of what their experience, to William's comment, the kind of perceptions and attention that opioids and that have gleaned over the last, really several decades. So all of those pieces kind of wrapped in. When you start to think about a biopsychosocial model around pain, you really start to see how impactful that experience can be for patients who have pain. So as I put here, empathy and then more empathy as part of that process. Again, really just to drive home that was my experience. I'm curious. Oh, thank you, Lauren. I was just going to ask if there's people who'd had similar experience. Lauren writes, the relationship and empathy were crucial with my patient with pain that took many more visits and was also challenging in a PCBH model of care, but made a real difference. Absolutely. How about for others? Is that consistent with others' experience in terms of feeling like that relationship piece took more time or took up maybe more time than compared to others? Kathy writes, many times I triage the damage done between patients and MDs. I do my best to honor the patient's pain or suffering and yet explain that many MDs are more scientists than healers. Sometimes it helps the patient to know that they may have an unempathic physician, but a brilliant scientist to take care of them. It's consistent with Patrick's experience as well. Gosh, and that's a great call out too, Patrick. You're saying it much more eloquently than I did. Empathy is a rare experience to many of the patients with persistent pain. And again, I would argue a healthy suspicion of healthcare, as you argue as well. but yeah, it really is a rare experience. Thank you for saying it that way. Again, both within the medical environment and outside, they oftentimes lack anyone who offers them any form of empathy to their experience. Annalise said, I would agree with it taking additional time to build rapport, increased hesitancy in patients' belief that a psychologist can help them with their pain. Yeah, that's a good call out too, versus their belief that we can help them with mental health concerns. So again, we get into this space as behavioral health providers, psychologists, many of us, around why are you referring me to, fill in the blank, shrink, whatever things I heard over the years. This is my back that's causing me problems, or this is my hip, or this is, I have headaches. I don't know why I'm here. Versions of that. Versus a lot of times it made sense to them why they were being referred to us for depression or anxiety as part of that. So that's also a really good call out, Annalise, in terms of the patient's belief around why am I here at behavioral health. And as we start to get into the explain pain model, I really try and empathize with that and then build on that for patients to acknowledge that given the ways that we've thought about pain up to this point, again, kind of speaking broadly there against the medical kind of world, was really, why would we refer a person with pain to a behavioral provider? And this model and many others really highlight that actually there is lots of reasons why that makes sense, and lots of reasons why that's actually considered best practice anymore. So thank you everyone for chiming in, and please do. So as part of the empathy, really the listening and learning part, and to the comments that have been made here, I'm really looking for, as part of that, the context and what their belief models are around their pain experience. So both what they believe and or have been told about it, but also listening for the context in which they talk about their pain experiences in terms of impacting their various social aspects of their lives. But I'm really trying to listen very intently around their belief model, because that's going to help also guide how much time I spend in, as again was commented on, that rare experience of empathy. And one patient I saw, as it pertains to kind of belief model, was referred to me for some ongoing neck pain. And as they were telling me about their experience, they expressed some pretty significant frustration with what they perceived to be inadequate, to put it kindly, care from their primary care provider, who this was an integrated care space, so I knew who that was, and I knew they were very competent and all those different pieces. But they were telling me about their pain and what they believed about their pain, and the person said that the primary care provider had referred them to physical therapy. And as the person continued to talk, they explained that their belief model was that if they turned their head in a significant direction, that they would actually become paralyzed because of their pain's kind of experience. Now, you can imagine how a referral to physical therapy may have sounded to that person's belief model. And that was something I was able to go back to the provider and talk to them about a little bit. But I just use that as an example. As you're kind of talking with patients about their pain experience, really listening in around what they've been told, what they what is, what's their truth about their experience. Hopefully, also if you have also kind of medical documentation or things like that that can help further contextualize what their experience is. But as far as working with a patient, I really want to hear, what do they believe about what's going on? Not any different than anything else, but for me, it's really important with persistent pain. And again, I use that as one example, but there were hundreds more similar to that in terms of understanding the imperative of understanding what a patient's belief model is about what they're experiencing. So a typical part of working with anybody is really trying to get some type of history. And I know as part of intakes, we all do that as part of it. But for me, I really am trying to do the history kind of spread through the reflective listening part. And there's a few aspects of the history of the person's pain experience that I want to highlight. But I'm curious for people on the call today, when you think about a pain history, what are some things you either do ask about or would want to ask about if you were to kind of start from scratch in looking at a pain history? How they coped in the past, impact on daily functioning, MI techniques, seeing what the patient can identify that has helped in the past. Excellent. What their support system is. Pain onset, duration, frequency of pain, any pain triggers. I might ask them what they think the cause of their pain is. Excellent. I want to know if they have trauma history. Definitely. What they would do if pain weren't a problem. Yes. What intervention they've tried before, which have been successful, describe their pain, a thorough medical history, and then determine what conditions involve pain, duration of pain, pain impact, treatment. Excellent. Yeah, so biopsychosocial factors. You all are highlighting a number of the pieces that I would include as well. And then Scott drops in, what activities and interests would patients like to do more of on a daily basis? So you all are already kind of really getting to the heart of what I see as the most important aspects of a history of pain, which are outlined here. Again, it's not exhaustive. If you look at the literature around, completing a pain history, there's a number of other things, but the ones that I've found most imperative to working with patients with pain are listed here. I list course as kind of a first part, and that's really as much about like whether it was a physical injury or things like that, as it is about what their experience with all of the things we just spent the last couple of minutes talking about, which is an injury occurred at some point, and then what has their experience been up to this point? And really trying to listen for all of those different types of experiences, whether with friends or family or medical providers, things they've tried. So again, somebody had commented from a motivational interviewing lens, which is very much where I bring this in from. But also I bring it in because I don't want to step in the same pile that a number of providers that I interacted with on the medical side stepped into, which is the patient already in their minds tried fill in the blank, and by recommending it again, oftentimes experienced that they weren't being heard. So I want to really understand, what have they tried, both so that I don't repeat things that they already have, and more importantly, I would argue, to not kind of invalidate what their experience has been up to that point. I would want to know about things that make it better or worse. And this can be anything. And in many instances, patients would talk about opiates, or they would talk about some other medication. I want to know about those things. I want to know, have they helped? I want to know about massage. I want to know about, laying down in this position or that position. I want to really understand what types of things make it even marginally better for them. And then, of course, things that make it worse as part of that. And you'll have, I've had a number of patients who really are able to highlight a number of activities, in many instances, activities they can no longer do or suffer as part of that because it makes their pain worse. A number of you hit on this, which is, what do they think is going on? Again, I can read the medical records, and those are helpful. But in working with the patient in front of me, I really wanted to understand, what do they believe? The person I was mentioning before about the physical therapy, again, his belief model around what his experience was really informed how we worked with one another. And that's a more extreme example, but again, not unique in that a number of patients that I worked with over the years who had some version of that explanation of their pain experience. A number of you commented on this: what limitations in function do they have? And I heard everything from, I can't stand at the sink to do dishes, I can't bend over to put clothes in the laundry, I can't get down on the floor to play with my grandkids, I can't walk more than 5 steps, I can't go to work, all of those different kind of limitations in functioning. And then a few of you commented on this, but what does better look like? And for this, I really want to focus in on functional goals, and we'll spend more time talking about functional goals as we talk later on. But less pain, albeit great, is not a functional goal. And so helping patients think about, how do they identify functional goals is something that, again, we'll spend a little bit more time on. But a lot of times they will say, I want to be in less pain. And I always say, excellent, and I hope for that too. And when you're in less pain, what are you going to be doing more or less of than you're doing today that we can work towards? And so really trying to get them focused on function and less about pain experience. And as we start to talk through the understanding of the model, hopefully that'll start to make a lot of sense, in addition to just kind of highlighting it in the chat from a number of you as to why we really want to focus on what are those functional impacts that pain is having on the person's experience. Now, I would be remiss if I didn't continue to acknowledge that even though some progress has been made, that substance use remains an important aspect of this work. And so ensuring that you do some type of screening, and again, I'm imagining the majority of you do some amount of substance use screening or a portion of your intake. But at minimum, it should be included in some kind of way as part of this process and working with patients with persistent pain. Not because, again, you'll necessarily be involved in the prescribing or deprescribing or whatever, but because of all of the pieces that we spent the first hour talking about in terms of the impact that it's going to have on your ability to be effective with this individual. So we'll talk through a number of screening tools. Of course, just doing a typical intake is fine as well, but I do want to just offer that there are a few different tools that you might consider as part of screening. And some of these you may have heard of. So the opioid risk tool really is super short, 5 items, self-report. At some point, can you talk about potential challenges, complexities around people using cannabis products for pain management? Absolutely. I can make sure and include that. If we get towards the end of the talk and I haven't gotten to it, feel free to ping me again. But I'll make myself a note here as well, just to make sure. So the opioid risk tool, again, is self-report 5-item. And the evidence for this tool really shows excellent discrimination between high risk and low risk patients. It has a high degree of sensitivity and specificity for those who are at risk for opioid use. This was developed specifically for patients with pain. And is, of course, it's 5 items. So it's quite simple, really kind of easy to use. There is one question that talks about the family history. So for some patients, they don't necessarily know that. And at least as far as I have seen the most recent literature, it hasn't yet been validated in non-pain populations. And if anybody on the call is aware of it having been, please jump in and say so. So those are a couple of considerations around that tool. The next tool is the screener and opioid assessment for patients with pain revised, which is a 24-item self-report. This too really identifies high risk and low risk patients relatively effectively. This too was developed specifically for patients with pain, as is probably obvious in the title. But it's easily understood by patients. Even though it's 24 items, it doesn't actually take that long to administer. Again, can be a really good tool to utilize as part of this process. And then the last one I'll mention here is the Dyer, which similarly has good sensitivity and specificity. This was designed for primary care use, particularly. And so for those that are in primary care, this might be an additionally good tool for a person to complete. Again, this one is different than the other two in that it's clinician completed. So again, taking a normal history is fine as well. It's not to say that you have to replace that with any of these tools, but these are evidence-based screeners that you can consider implementing as part of your process. I'm curious if there are others that people are familiar with that they might recommend for the group as well, if you wouldn't mind dropping those in the chat. Spencer comment about the 10-point pain scale. Yes, wink, wink, yeah. Any others? Well, again, if you're not familiar with some of these, hopefully one or two of them might pique your interest, but again, are validated tools to be able to really acknowledge that substance use remains a very large problem as part of this work. And so ensuring, as I'm sure you all do, that we're screening for it, but especially with patients with persistent pain. So once I have gotten to really through that first appointment, and in some instances, the first 2 appointments, and in very, very rare instances, the 3rd appointment. Again, once the patient has been able to start talking to me about anything besides their pain experience, that to me is an indication that I can move the conversation forward. Now, again, if I do that and they right away start to talk to me more about that, I know that I missed the mark, that more empathy, more reflective listening is needed as part of that. But I will oftentimes kind of set up this conversation as as one of the people put in the chat, through a motivational interviewing lens, that a lot of times they will highlight some particular functional goal that they are no longer able to do, whether again it's getting on the floor with their grandkids or something. And so I will do some motivational interviewing phrase that acknowledges the things that they're doing that have helped, even if it's a small amount, and then acknowledging the areas that they're struggling with, and really opening up the question as to would they be interested in learning tools that will help them be able to stand at the sink to do the dishes, to go for a walk, to do whatever it is those functional goals that they've identified are. And again, if you've done it right up to that point through that relationship building, they will most of the time be open to that. And so once that door is open, what I start to talk to them about is this explain pain model. And so you'll see the cover of the book here. There are a number of unique drawings in this book. And in my experience, this book is really clinician focused, and unless a person has a significantly high health literacy, I don't generally recommend that patients get this book particularly. There is another book that these authors write that I will talk about a little bit later in the presentation, that if you would like to recommend a book to a patient, that would be the one I would recommend. This one, however, is one that I'd recommend for you all, although I will do my best to kind of highlight pieces of it today in terms of how I've utilized it. The additional reason why I don't typically recommend it is, at least last I checked, is about $90. And that's just cost prohibitive for a lot of the patients that I used to work with. And so it's a good reference book, but not one that I would typically use or that I would recommend for patients. But this is where the information we'll talk about comes from. So starting off, what I would do with patients is say, the way that we talk about pain in this clinic or wherever is aligned with this book, and is really composed of 4 pieces. The first piece is all pain is real pain. And that is a both part of the model, but is as much a comment towards where we spent the last little bit of time, which is whether we can see it on an image, whether we can't see it on an image, whether we can prove in quotations that the person's pain experience aligns with what we see on imaging. None of that matters as it pertains to this model, in that the patient is experiencing pain, and that's their experience. And that's it. That's their experience. And so as part of this process, it acknowledges that the person's pain experience is just that, their experience, and one that, as has been highlighted, trying to challenge or kind of prove to be untrue often just leaves that person feeling invalidated. And so why this is the first place to start is, in addition to the empathy, will make sense when we talk about the second bullet point, our second kind of component of this model, but really focusing in on all pain is real pain. And I will weave in, as part of the educational part, that history that they have talked to me about. Whether it was that imaging that came back and appeared to be normal, or the doctor who said, well, we see some decompressioning of the discs, but we wouldn't really expect it to cause the type of pain or the amount of pain that you're experiencing. And I won't spend, at least as part of this talk, talking through, but there are some really great data that talks through limitations around things like imaging or lack of imaging as it pertains to a person's pain experience. In so much as there have been a number of studies that show you can take a group of people who have back pain and a group of people who have no back pain, and you can separate them out and do imaging on half of each, and half of them you'll find that there's some amount of damage in their spine that could cause some type of pain experience, yet half of those people experience pain and half of them do not. And then you can take, again, the people who are experiencing pain and do imaging, and half of them will have no damage, and then half of the group that's healthy will have no damage. So when we start to, and again, there's a number of studies that talk more about it, but there's a number that really show that things like imaging or things like that are not always very good explanations of what makes quote unquote a real pain experience. And there'll be a number of other examples that I'll offer as part of the remainder of the talk. But the second bullet point, according to Explain Pain, is all pain is in the brain. And so, Linda, I can only see your face, so I'm going to pick on you just for a second, but your face just showed what I think was what a lot of patients experience, which is kind of some version of or really, or okay, are you going to be like all those other doctors and tell me it's all in my head as part of that. So I don't know if I caught your face correctly, Linda, but
please say it.
Oh.
To check your balance, I will.
Oh, I was hearing someone's voicemail or something. But the second point is all pain is in the brain. And basically helping patients, and we'll spend more time talking about this after the next break, which is that all pain experience, all conceptualization of it occurs through the brain, like all of our other conceptualizations and feelings and beliefs happen. And so it's not to say that they're imagining it. It's not to say that they're making it up. It's not to say that they're mentally making it worse than it is. It's just that that's biology, that our experience as it pertains to this model is funneled through the brain. And as part of that is what determines the pain experience that we have. So for those of you that are looking at the slide, what happened when I showed that picture? You wouldn't mind dropping in the chat. A cringe, okay? Chest tightening. Any other experience? Wince, fear. You wince. Feel a twinge in your foot. Skin crawling, tingling, tense. Gonna need a tetanus shot. Cringing from head to toe. So I use this photograph as part of the work. Brought up a memory when I stepped on the nail. Sadly, I have a few of those as well, and tetanus shots to go along with them. But yeah, so I use this when I'm talking with patients to help to highlight the point that you can look at an image and you are not actively stepping on a nail, hopefully, and yet you have a physical experience. You have some type of cringe, tightening. I've seen this image, I don't know how many times, and it still happens to me, even hundreds of times later. And so I use this as a way for patients to really understand that when I say pain is in the brain, it has literally nothing to do with them imagining it or them kind of making it worse or making it up. It's exemplified in this image that your brain is interpreting information and having a physical experience. That's it. Not any different than when you watch a movie and start to cry based on what you're experiencing, or feel joy in watching people enjoying the sunshine. I mean, it's all of those types of things, and really helping people understand that even though in many instances there is physical damage, it really still comes down to what your brain thinks about, and we'll talk about that more in the next couple of bullet points. But again, using this image or some version of that to help patients have the same type of experience as a way to show them what we mean when we say pain is in the brain. So then I show them some version of this. Curious about why people have such different pain tolerance levels. And we'll talk a little bit about that. The kind of idea of pain tolerance is also one that, at least in my review of the literature, is somewhat kind of questionable in terms of what that is, because again, what a person's experience is such a powerful piece. And even though it sounded like there were similarities in terms of experience with the nail, I would imagine the intensity of that experience varied. And we didn't ask the group of what their 1 to 10, again, not that I advocate that way of assessing pain, but just for like a rudimentary example, I would imagine if we asked, Karen, Emily, Kathy, Alexandra, how intensely did you feel that? We'd probably see some variability. Now, that may be because Alexandra stepped on a nail before, or people have had lots of other experiences. So it's a pretty complicated question. I'm not sure I can do the world's best job quantifying it. But just to say it varies a lot for lots of different reasons. The idea of trauma was brought up. Of course, people with depression experience higher pain experiences as well. And there's a number of other kind of pieces. So I'm happy to say more about it at the end today too, if people have more interest in that. So again, if we go from this image where we all cringe, and I still cringe seeing it again, what does this do? What does this do to that kind of focus on the nail? Now it's LOL. I'm not sure if that's laughing out loud or yes, okay. The foot's laughing, or the hippopotamus is laughing, or yeah, reduces anticipated pain experience. Yeah, so again, the brain has to reprioritize. And we all know this from just kind of early biology courses, that our brain has to prioritize. Even as we're sitting here now, you're prioritizing based on the experiences you're having in the chair, or couch or floor. Oh, yeah, it's not meant to be like a super threatening image, but just again to prove a point for people that you can have back pain, you can have hip pain, or you can be the poor person who's going to step on this nail, and that experience of that particular thing is going to change if you're being chased by a bigger object than you. And so it's really just to drive home that point that that doesn't change the fact that you stepped on a nail, but somehow your brain is thinking about it, to use that word kind of really loosely, thinking about it differently because of different environmental cues that are going on. As I mentioned, even in this moment right now, you're prioritizing, thousands of pieces of information as we're talking this through, and having to prioritize that. And again, I would imagine there are some of you with pain who maybe when you saw that initial image, maybe for a split second, your pain wasn't as noticeable or potentially was heightened as part of that. So again, it can really fluctuate what that experience looks like. So I use images with patients through this, partly because I feel like it does a better job explaining it than I am able to do, but gives them a tangible yet hopefully not very threatening way to interact with how their brain is conceptualizing pain, and how that is something that is modifiable, that we can do something with. Because as the rest of the talk moves forward, that's really where we want patients to see that they have efficacy in the work that they do, and there will be things they can do that will be effective as part of this process. So again, first bullet point, all pain is real pain. You cannot overemphasize that. And then all pain is in the brain. So I will pause, even though you all have been doing a great job dropping comments and so forth, for any additional questions. Again, I'm tracking the ones that I can round back to as well, but if there are other ones that people have. Okay, let's do another break. We'll come back at 10 o'clock again, and we will pick up with our third bullet point. And are you back? There we go, you're recording.
I'm
awesome.
here.
Awesome. All right. I just want to make sure we started the recording again. All right. So welcome back. So as we've talked about, the first two bullet points or kind of tenets of this model as I see it, all pain is real pain. All pain is in the brain. The third, which is tissue damage is neither sufficient nor necessary for pain. And I'll talk a little bit through the example that I used with patients to really show what I mean by that. So said in just a slightly different way before I move into the story is, it is the perception of the threat that determines the output, not the tissue damage itself or threat to the tissues. So again, we all kind of understand what that means, but I didn't oftentimes say it that way to patients. How I would say it to patients went something like this. So there is another book written by one of the authors of the Explain Pain model, Lorimer Mosley, who also writes this book. And as you'll see in the title, it's Metaphors and Stories to Help Understand the Biology of Pain. So this book, at least last I checked, was like $7 or $8 or something like that. It's quite more affordable. But the story that I took out of this and would tell patients to exemplify that third point was a story that comes out of this, which is he tells a story about how he is walking through kind of a brushy area. And keep in mind, this person, is a pain researcher, does pain all the time, and so should know kind of all things about pain. Maybe does know all things about pain, but is telling this story about how he was walking out in the kind of brushy area and felt a scratch on his leg. Now, if any of you have hiked, done gardening, worked on a vehicle or something else, chances are you have had some version of a scratch, or sometimes more than that, and you didn't really even register it. I know I have had many instances of those where I walk in from the garden, or doing yard work or whatever, and there's a little blood on my shirt or a little bit of blood on my shorts, and I realize, oh gosh, you know what, I scratched my arm, or something like that. A similar experience might be somebody who wakes up with a bruise somewhere on their body, and they couldn't for the life of you tell you where they got that bruise, but clearly there was physical damage that occurred as part of that. And I would always, as part of, again, telling this story, ask patients, has there been a time where that happened to you? And I don't remember a time where any patient said, no, that's never happened to me, where I wasn't involved in something, got a little bit of a scratch and didn't even realize it at the moment until later. Now, we all can agree there's physical damage that happened there. You can see it. There's blood or a bruise or something, but yet it didn't really register with the brain for all sorts of reasons. You of course hear about some of the kind of famous reasons in terms of people getting really significant injuries and still are able to kind of go through that. And the hippo image gives a little bit of that, but it's more relatable, I think, for people when I ask, again, you done that gardening or working on a vehicle or doing something like that? Seemingly everyone's had at least some version of that experience. So this, Dr. Mosley is walking through and again feels a scratch on his ankle. Again, anyone who's done any hiking, that is typical, at least for me. And so he continues to walk and eventually realized that it wasn't a scratch from a stick, that it was actually a snake bite, that he'd gotten bitten by the second most poisonous snake in the world. This was in Australia. And needed emergency medical care as a part of that. So again, he tells this story to prove a point, or I use it to prove a point as it pertains to this other model, which is if it were simply a correlation between pain and damage, that should be more proportionate, that the person should experience pain proportionate to I'm going to die in a matter of minutes if I don't get emergency medical care, as opposed to being scratched with a stick. But that's not what happened. And again, there's smaller versions of that when we talk about being scratched in the garden or those types of things. But I tell that story for patients because it's easy to remember, but it helps them understand that gosh, this does happen, and I've even had that happen, and yeah, that is true. And so you're starting to create some curiosity and wondering. Oh, yeah. William put in there, we're mountain bike riders in Oregon. Many times we'll come home with blackberry vine scratches, some deep in blood, and just laugh. No real pain until you clean up. Yeah. Absolutely, I have a bunch of blackberry bushes out here. When you try and clean them up, you're scratched everywhere. And so again, I use that story and to really highlight the point. So this is an image of that snake, not literally the one that bit him, but just a Google version of that. But pain can also get it too right, and what I mean by that is the fourth bullet point. So again, we have all pain is real pain, all pain is in the brain, And then tissue damage is neither sufficient nor necessary for pain. So the kind of sub bullet point really highlights what he discusses in this story, which is it's the perception of the threat that determines, not the tissue damage. So in his story, there was significant tissue damage and significant threat to his life. Again, he would have died had he not had some type of emergency medical intervention. But yet his brain perceived it to be a scratch from a stick. And to William's point, that's just part of going mountain bike riding. It's just, that's part of the experience. So you don't perceive it to be a threat. But something changes in that process. And so that's where we really get to the fourth, which is pain doesn't necessarily equal harm either. And so it's the reverse sort of ish of the third bullet point, which is damage doesn't necessarily equal pain, and pain doesn't necessarily equal damage. Now, without getting too far into the biology, because I know all of you are aware of this, pain exists to teach you something, we all think about, or at least I do, because I have 2 kids at home, younger kids, like if you put your hand on a hot item. We had our first corn on the cob from our garden last night, and my youngest went to grab one, and I told him they're still hot, and he thankfully didn't grab it. But pain exists for a reason, to get you to do something in response to that. So the understanding is that it's a messaging tool. But especially within persistent pain, it's oftentimes lost that, at least to a point, the functionality of that particular component, which is, again, the fourth piece. So the model really is those 4 points. And I will explain it to patients, again, after I've done relationship building, after they have told me all of the functional pieces, and they're open to learning about something new. I will say, here's the model, and here's the 4 points. In a primary care setting, again, this would typically be an appointment, 20 to 30 minutes, and I would just focus in on this piece, because this is oftentimes different than how many of them have thought about pain up to that point. So it's really important that they understand these 4 pieces of it. Said simply, pain is the answer to the question, am I in danger? And so said just really succinctly, that's what I really want patients to leave with, kind of contemplating is, I experience pain when my brain tells me I'm in danger, not necessarily when my body has been physically damaged. So those are the 4, even though I add the bottom one just to kind of say it a bit more simply, but that's how you can summarize what the pain experience is for an individual. So even though we're not at the end of the hour, I do want to just pause there and see if there are any questions on that. All right, see none, unless you're still typing, and then I'll get back to it. So unpack that last bullet point. Am I in danger bullet point? Yeah, so in telling those stories about like the snake bite or having people talk about their experience in the garden or whatever, in all of those instances, the theme to not experiencing pain, and to William's comment about riding mountain bike riding, in none of those instances did the person perceive themselves to be in danger, even though probably not with the gardening and not with the mountain bike writing, but definitely with the snake example, you very much are in danger. And so it's really comes back to what the brain is perceiving around that threat level. So the person that I spoke about earlier on, when his what his brain is telling him about, am I in danger? If I believe that turning my neck in a certain way was going to cause me to be paralyzed, that is a very significant danger interpretation of what that person's body is telling them. And again, significantly heightens what their pain experience is going to be as part of that. So Reagan, let me know if that didn't help, and I could try a third pass at it. Spencer, can you talk about the relationship between perceived pain and experienced suffering? Oh, I think of suffering as a very broad topic, so I'm not sure if I'll get to exactly what your question is, but to me, the suffering comes into the impact of function. The pain causes fill in the blank for the person, and that, at least in my experience, is more where it kind of transfers into suffering, in so much as I can't work anymore, or I can't get on the floor with my grandkids and play. I can't be intimate with my partner because it hurts too much. I can't, maybe I don't have a relationship anymore because that partner got tired of me talking about what my pain experience has been. I can't play catch with my kids. I can't. That for me is the suffering that I heard in working with patients. So it was less about, my pain hurts at a 12 out of 10. It was, this is what pain has done to me or has done to my life as part of that. So I don't know if that was anywhere near what your question was going for, Spencer, but let me know if I missed the mark. But that's where I see suffering and pain kind of connecting and at least going together. And I'm curious if others have other thoughts too. If you'd like to add those in, please do. Yeah, so Reagan just commenting, I'm thinking a lot of folks experiencing persistent pain would say the pain is telling them they are in danger. And yes, that is exactly right. That is what that's what they believe it to be telling them, which is again where we're with persistent pain. Pain no longer, or not entirely, again, not to generalize across all of them, but at least as it pertains to that, is in many instances, the damage was done decades ago. And so being in danger in that instance, pain is supposed to be kind of an acute experience to say I'm in danger like in this moment. But when it's lasted for decades, as is many times the case, the actual danger of like further physical injury or things like that isn't likely based on kind of whatever the doctors will kind of determine as part of that process. But you're right in that the patients they're still experiencing that as a threatening message. And that's part of what we in this work are working up towards, is helping them to understand that it's a message, and in a non-persistent way, it is normally communicating that, but has kind of moved past that at this point. More of a single signal than an answer. Yeah, I think that's totally fine too. It's a message, and it's up to us to determine what we want to do with that piece of information. So yeah, I think that's very reasonable as well. And very much, yes, Spencer, represents a threat to their capacity for existential well-being. Absolutely. And that's where the suffering part for me comes into. It's less, although, there's still aspects of the pain that are impacting them, but it's really what does it do to them and their life and their ability to do all the parts that we think about in terms of a fulfilling life. And then Emily provides a comment too. One thing I learned in previous pain workshops is pain is inevitable, but ongoing suffering does not have to be. And yes, I've heard that too. And for me, that again starts to speak to what a person does with that pain message or signal, as Reagan commented. It's what do they do with that information? Because in some instances, it again is still communicating threat to them. And part of our work is how do we give them a different script in terms of how they understand that signaling to occur. So thank you all for your comments, and please keep them coming. Just to highlight a couple of pieces here with persistent pain. So a lot of times patients, as they, to Reagan's kind of question and comment, will say, but I'm in danger. This is telling me that I still have something wrong with my back or my shoulder or my neck or whatever. And so I start to explain some of these other pieces in terms of how does it go from an acute pain experience to a persistent pain experience, and how the messaging that you are receiving is no longer communicating the same types of things that it was initially intended to do. So sensitization is part of that process. So as we've all probably experienced, if you've had any injury, is you have increased sensitivity to pain as part of that process. If you sprain your ankle or something like that, you're going to have increased pain experience. That's part of, again, the body saying, we got to protect what's happened. And so you'll see as part of those, you'll see allodynia, and I don't always kind of use these terms, but just for this group, I'll use them, which is pain with things that typically wouldn't cause pain. And then hyperalgesia, which is increased sensitivity to pain. So both things that didn't previously cause pain and then just increased sensitivity to a pain experience are part of that. And so the understanding of the biology of pain is that those are normal as part of an acute pain experience, but should fade over, quote unquote, reasonable healing time, which, is going to vary depending upon the injury, of course. So educating people, and that's kind of what a typical pain course would be. But what we see is that persists in chronic pain, both things like allodynia and the hyperalgesia. It doesn't fade in that kind of normal time course that we would expect. And we start to see things like central sensitization. And so in the book, they drew out kind of these dual peaks. And so I did my best to kind of replicate them here, but there's a much better drawn version in the book itself. But I will show this with patients in terms of how the persistent pain experience has changed them. And so you'll see on the left-hand side, and again, when I was seeing patients still, I would do so in a primary care environment. So I would just grab a piece of paper and just do a kind of rudimentary drawing for them, but basically would highlight these pieces. So I would do a before injury and after injury map, just like what you see here. And so I would show them that with a typical kind of pain experience, you have a protect by pain line. And again, this is all from the book in terms of how they explain it. which is you have a protect by pain line. So again, pain is generally meant to protect you, to say, don't put your hand there, or take your hand away, or something happened, you need to respond to me. You need to look at your ankle. You need to pay attention to this thing. As Reagan was pointing out, it's meant to say you are in danger. It may not be life and death kind of danger, but there's some damage happening to your body. And that's what pain is supposed to tell us. Ideally, it does so before that kind of tissue tolerance line, or where the damage of tissue occurs. So, or at least significant amount. But what we see after injury is an adjustment, meaning that the tissue tolerance line, because again, a part of our body has been damaged, lessens to a certain extent. I've played a lot of sports in my life, and so I know that it doesn't take much for me to sprain my ankle at this point, and because I've done it so many times, and so the kind of tissue tolerance adjusts as part of that. And we see that after injury, that line is going to adjust. You'll also see a significant reduction in the protect by pain line. Again, the body's trying to tell you, take it easy, we got to heal things here. What it starts we start to introduce is this flare-up line, which is the body starting to have kind of a physical and a mental response to an exacerbation of that. And so you'll see this recalibration, if you will, of where the baseline is for the person. Because what will happen is they will kind of push up against the flare-up line, and the body continues to kind of remind them that this injury is there. And so the baseline starts to lessen. And patients can empathize with that the minute I mention it, because they've already spent the first appointment or potentially multiple appointments telling me that they're not, in many instances, able to do any of the things that they used to be able to do, or at least not to the level or the intensity that they would be able to do them. One, in some instances, not at all. I've had many patients who will say, I just can't fill in the blank. Or if I do fill in the blank, I'm down for the next couple of days, or I'm down for the next, couple of weeks, or my pain's significantly worse. So they can empathize, explain the tissue tolerance line. So in the book, they talk about it as kind of, that's where damage, like physical damage, occurs. So thinking of again, putting your hand on towards a warm object, you'll start to feel some discomfort. You may not describe it as pain, but you'll start to feel some discomfort, and it's supposed to say, stop that. Don't go any closer, those types of things. Again, there are many injuries that, of course, if you fall or get hit by an object or something like that, that your body doesn't have the opportunity to utilize it in that same kind of way. But tissue tolerance is basically just kind of the damage point, as far as they talk about it in the book. And so for patients, they can really see that, yeah, my prior baseline or my protect by pain line is markedly less now that I've had pain for fill in the blank amount of time. And part of that has to do with the prior slide where we're talking through the hyperalgesia and the allodynia pieces, where the brain really becomes kind of hyper focused. And so we'll spend the next couple of slides talking through a little bit more about how we think that all happens. And one of those pieces has to do with neuroplasticity. And so there's lots of books on neuroplasticity. We don't have enough time, and I know there's people on this call who know much more about neuroplasticity than myself. But as I introduce it to this, I really am introducing it with the lens that we can modify what their experience has been, or excuse me, we can modify what their experience will be going forward. And that has to do with neuroplasticity. And I asked just a silly question of them to lighten the mood, but also just to emphasize a point when I'll say, how did you put on your pants this morning? And they'll most of the times laugh or kind of look at me kind of questionably. And they'll say, oh, I don't know, I think, one leg at a time, or some version of a response. And a lot of times people can't remember, actually, because they've done it so many times that it's such a routine piece. And that really has to do with our brain making things efficient so we don't have to think about them. And so I say to them, well, what if I asked you to go home and put them on next time both legs at the same time, assuming they didn't say that's how they did that the first time. And then I'd say, well, do you think you could do that? And they would say, yeah, I might have to think about it a couple times and it might be hard or whatever, but I could do that. And so utilizing that again, both to help them understand that how the brain kind of creates these pathways over time and how they can become very routine, but also to start kind of adding some information in for them and we can modify it and we can improve things as we go forward. I just include the image because I have as I mentioned, two kids who still are questionable in terms of getting themselves dressed and oftentimes end with their pants on their head and all sorts of things. So, again, you all know this, but the brains and nervous system are constantly changing. If the putting on the pants example kind of falls flat with the person, I just ask, can you tell me about a time you learned something new? Whether it was playing an instrument, playing, a card game, whether it was, any number of skills. Can you tell me about a time? And they, can always tell me about some type of time that they learned something new. But starting to really highlight the fact that we can start to impact these pieces of information. So you all probably remember a picture or at least a conversation about this in graduate school, and maybe it's been since then. But depending upon the patient's experience, this is something that I will bring up to them. And as they start to mention things like, well, I have the injury in my back, but now my hips really hurt and my legs really hurt. And it seems like it's no longer just on the right side of my back, but it's also in the kind of middle, and it seems to have gone to the left side. And so their interpretation, to get back to Reagan's kind of comment earlier, is there must be some damage that wasn't seen on imaging, or somehow the damage I had before has spread in some kind of way. And again, throughout this whole process, I'm of course collaborating with primary care, or if they have, other specialists. And so it's assuming that all that stuff is still continuously being evaluated and so forth. I kind of start to talk to them about what is the homunculus and what do I care about this goofy word as it pertains to my pain experience. And so helping them understand, as many of you do, that it's really kind of a map of the body and the brain, that different parts of the body are mapped to different areas. And that, it's going to vary to some extent. So it's not meant to be like, this is exactly what it looks like in everyone's brain. But as you all know, just to kind of give people more of a concept rather than, exact information, helping them understand that when you start to look at these pieces, the pain experience will oftentimes start to move, or what they call smudging. And there's this study and many other studies that talk about the more chronic the pain experience, the more smudging that occurs. So the more kind of brain space the person starts to have consumed by that pain experience, the longer that it lasts. And at least some studies believe that this is how we can explain the phantom limb experience as well, that it's the brain basically has determined that there hasn't been enough resources dedicated yet to resolve the issue. So let's recruit kind of our nearest group and kind of bring them into the fight. And then it kind of grows from there. That's how I oftentimes help patients understand, well, how come my injuries in my back, but now my hip hurts and my leg hurts, in addition to the fact that they've likely done other compensatory behaviors in terms of they've shifted their gait, or maybe they sit down a lot more. There's of course all those other contributing factors, but part of it has to do with this, with these pieces as well. So before we jump into the what do we do after the psychoeducational part, well, let me pause for questions or clarifications, or if again, I know there's lots of experience on this call, so if there are parts that people have learned differently or that you explain differently to patients that you feel like would be helpful for the group to know? Or any updated kind of studies on any of these pieces that you want to highlight? I think someone said they're doing their dissertation on it, so chances are you have lots of pieces to add to. So if you'd like to. All right, not seeing any comments, but if you're still typing them out, I'll round back. The tissue tolerance line is just meant to indicate like that's where damage occurs, not necessarily more easily. It's just it can become more easily if there was already damage there, but it's really just that's where damage occurs kind of to begin with. Karen, if that hopefully clarifies. I don't have much to add, but it makes me think about functional pain. Yes, it does lower over time based on their kind of modeling. Again, attributable to damage that's occurred in that area. So, back pain, if they've damaged some portion of their back, in a persistent pain experience, they generally have not been able to recuperate back to the level. So that's not to say that all of us experience that, but for those with persistent pain, they oftentimes haven't been able to do physical therapy and do some of these other parts that bring their tissue tolerance line kind of back to where it belongs, if that helps. I have a patient with muscular spasticity. So the pain is related to progressive illness, but also chronic. Yeah, it's like ALS. Yeah. Yeah, for that particular, and I had a number of referrals. I used to work with a behavioral provider in the neurology department as well, so I have had a number of patients who with ALS and other kind of conditions. For me, the kind of psychoeducational parts can be helpful to a point, but as you've already highlighted, with a progressive illness, some of the strategies, I really focus more on what we'll spend the last part of the talk on, which is some of the behavioral strategies around values alignment, whether you're working from an ACT lens or cognitions about what that person's experience is, if you're looking from a CBT lens, But then there's other parts that are talked about in this book as a because they're physical therapists that also talk about what that from a physical therapy standpoint, ways that you can work with them. The patient can work with their bodies differently. So it really be kind of a mixture of things. But you're right in that there are certainly unique circumstances as it pertains to illnesses like that, where you would need to modify. And that's how I typically modified it. I would still offer some of the psychoeducational part that we've now spent the last chunk of time on, but really focus more in on some of the behavioral strategies that we'll talk about now. Yeah, and thanks again, William, for offering just some personal experience in terms of pain in one knee, but kind of referred from the other side as well, and that's and then shoulder pain running down your arm. Yeah, I mean it's thank you again for sharing your personal experiences, and I'm imagining all of us have had some versions of pain and potentially persistent pain as well. And so you can think about how this has impacted your life in ways that it's been explained to you as you start to think through this process as well. So when we look at behavioral strategy, so as I mentioned, my first appointment or two really focuses in on that pain history through that empathetic lens, really trying to get that those functional goals, listening for what's gone well for the person, what impacts their pain positively or negatively, what is better look like for them, and then once the conversation has shifted away from a kind of pain focused conversation, offering those educational pieces, so those 4 bullet points, and then as relevant, talking more about some of the most recent slides in terms of the smudging, and again, I catered that to whatever the patient's experience was, so it wasn't kind of I talked with everybody about that. The 4 tenets I very much discussed, because that's really helping them understand that is essential, in my opinion, to getting them involved in beyond education. What do we want you to do about what you're experiencing now? But those other parts I would kind of cater depending upon the particular person. And so the educational part, I then want to start to say, okay, now that we agree, or at least the person's still willing to listen about what the pain experience is, what it's trying to tell us, especially in a persistent pain environment. Yes, it's communicating danger still. However, as far as the medical personnel are concerned, there isn't a threat to increased movement or things like that. Here's what we understand about it. Then we start to talk about, so now what do we do? So these will get lumped into a couple of different buckets. So pacing and graded exposure, accessing the virtual body, addressing the sims and dims, and I didn't make up words there. Those are come from the other book that I'll reference from these authors, and will make more sense when we get to that. And then the behavioral strategies, which I will actually spend less time on today, because there's a lot we could talk specifically if we come from like a CBT lens or an ACT lens or kind of an other lens as it pertains to behavioral strategies. And I'm assuming that many of you feel comfortable with your theoretical orientation, whether it's CBT or ACT. So we won't focus a ton on that, but just kind of acknowledge that there are significant aspects of what a person believes about it, which hopefully feels obvious at this point, about their pain experience, that CBT and ACT and other interventional tools are very much evidence-based and can be very effective in terms of addressing the person's beliefs about their experience. So circling back to this graph for a minute, I will remind the person of what this graph looks like. So again, kind of highlighting that because they've had pain for a decade, 2 decades, 3 decades, however long the person's had that experience, their baseline is pretty low as it pertains to their pain experience. But I really want to couch that in their functional goals. You've told me that you can experience 1 minute of doing dishes before the pain just gets to the point that you can't stand there anymore, or fill in the blank for whatever. And I always try and highlight what are the things they want to be able to do more of. It'll vary depending upon the person, but I really want to try and utilize that as a motivational interviewing kind of tool to ground it in what it is that they want to focus on. So that's where I'll typically reference 1 or 2 of those pieces. You've said that you can do X number of things for X amount of time in up to your kind of baseline. And so I then start to talk about, this is the kind of physical aspect of the work that we'll do with one another, which is we have to acknowledge that your baseline is, I can do 1 minute of whatever, or I can do 10 steps of whatever. That is your experience. And we're going to start from that. But for some patients, they're not exactly sure what that looks like. And so I really want us to try and quantify it as much as we can, and getting them to do that either in time or in repetitions or in some other kind of way. We really want to try and quantify it. So again, I'll use one example that I've mentioned where I had a grandmother who wanted to be able to spend time playing with her really young grandkids on the floor, and would describe that she could spend, she estimated about 2 minutes or so doing that. And so I asked, would you be willing to kind of track that for a little while, and just see if that, if on average, that's what it comes about to. And so this is just an activity log that I found off of actually a college counseling website, but there are many others. So I'm not necessarily pushing one or the other, but this is one that I found really helpful. And so so this is the front side of the form, and this is the back side of the form. This slide's got in here backwards, I see. But I basically want them to track some version of what they're experiencing. And I utilize this functional capacity scale. Again, you will notice that it doesn't ask about pain. It asks about function, their ability to concentrate, their ability to engage in activities, concentration, kind of those other pieces. Of course, those are all influenced by pain, but it doesn't ask about pain. And that's, again, furthering the conversation to try and get them to focus in on function rather than the pain experience itself. So I'll typically provide them the education around the kind of dual peaks, and then I'll say it's important for us to get a baseline, partly because it lets us know where we're going to start from, but it also allows us to then start to quantify improvement as we go forward, as well as how aggressive or not we can be in working with the graded exposure component of this. So in the primary care clinic that I was at, I had the luxury and the pleasure of working with a physical therapist who was with us. I think they were with us a couple of days a week, and so she and I worked a lot with one another and working with patients with persistent pain. And so one of the things that she introduced me to, as you start to think about creating this graded exposure model, is the better, same, worse rule. And so for some patients, utilizing this chart and this kind of functional capacity scale was helpful. For some, it seemed too big or too complicated, and so that wasn't going to be helpful for them, and that was fine. And so we had them do some version of a chart. It could be on their smartphone, it could be on the back of a old bill, it could be wherever they did it. But what I asked them to do is anytime that you're engaging in an activity, identifying during, after, and then oftentimes 24 hours-ish after, are you better, same, or worse? And that starts to help people identify if they don't come in with a real clear picture of what the functional impact of their pain is, starts to help us quantify what that might be. So they may say, again, back to the patient who was with her grandkids, and she would say, I ended up watching them a little bit on Saturday, and I was on the floor for maybe 5 minutes one time, and then I felt markedly worse about an hour or so, and then by the next day it was much worse. Or fill in the blank other kind of version. We're really trying to help them understand how much gets us in better, same, or worse. And we circle it back to this when we start looking at the graded exposure model. If you can remember back to the dual peaks, you'll remember that the flare-up line and the protect by pain line has markedly decreased through a persistent pain experience. So the amount of exertion, if you will, that exacerbates that has lessened pretty significantly. And so helping us understand where that is, because again, pain is as an individual's experience, is important. But it's also important because the brain is going to continue to utilize those messages if the person continues to push over the threshold in a significant amount of way. The brain will basically say, you overdid it, and I need to remind you, even though they're kind of being reminded regularly. How I would explain to patients is they just, your brain is saying you've overdone it, and now you're gonna have increased pain for a period of time. So as moving the graded exposure forward, I really want patients to understand that we want to avoid that at all costs, or not to sound catastrophic about it, but as we really want to encourage ourselves to not push into that space more often than we need to. Because I heard many times over, also from patients, that they would say, well, I kind of rest up for a couple of days, and then I push myself because I couldn't do grocery shopping, or I couldn't do the dishes, or I couldn't vacuum, or whatever up to that point. And then I pay for it. I'm down for the next 3 days. And it's this vicious kind of peaks and valleys cycle. And so helping them get with the dual peaks model, but also with this better, same, worse rule, understanding as you start to work on graded exposure, it's really important that we not push too far into that space if we don't have to. So once we've identified that, and I've talked to them about how graded exposure will be helpful, and again, graded exposure in this context is the same as you would use it in like an anxiety disorders or any of those other spaces that I know you all are very familiar with. where we would really want to do kind of specific incremental improvements, and utilizing, in some instances, kind of specific increments. But for some patients, we have to, it's a little bit more trial and error, which is where that better, same, worse rule is. So for that patient who wants to be on the floor with their grandkids, we may say, I would ask her, what feels like a reasonable amount of time that you might want to try and add on, and see, 5 minutes clearly was too much. You told me that, but it sounds like we have space between 2 minutes and 5 minutes that maybe, and really treating it like an experiment. Let's figure out, is there an amount of time that can increase that? And so we set whatever that increment is going to be, and then we have them utilize that better, same, worse rule to then categorize. The day when I did 5 minutes, I was worse an hour later and 24 hours later. But the day that I did 3 minutes, I maybe was a little bit worse an hour later, but 24 hours later, I didn't notice that I was worse. And so utilizing that from an experimental standpoint. But what we're building is essentially kind of an exposure staircase for the patient to be able to slowly start pushing that protect by pain line back up. Now, as part of that, I had lots of patients who would say, well, I can't do any of what fill in the blank activity. I can do 0 minutes, 0 repetitions. And whatever that activity was, important to them. And so as part of that process, I would start to talk to them about the virtual body. And they talk a lot about this in the book as well. And but highlighting the benefits of doing many of these activities, and there's lots of research that talks about this specific to pain and a bunch of other things that I'm sure you all are aware of in terms of you get very similar benefits even by starting with the virtual experience. For those of you that maybe you haven't had a chance to yet, but in the most recent Monitor, there is an article actually on pain. And one of the stories that they highlight in there is about virtual reality and the impact that has on people's pain experience. And yeah, if it's okay with folks, I'm going to just kind of push through for this last chunk. But by all means, if you need to take a break or whatever, please do so. Just because I want to make sure and leave some time for questions and elaboration at around 11:30. But really highlighting that the virtual body is not a substandard place to start if that's where the person's at, and can be a really great add-on as well for people who would like to do it. So in the book, there's a list of different ways in which you can not only utilize the virtual body, but start to change the relationship with movement. Again, these are physical therapists, and so they kind of highlight a number of these pieces that are ways in which the person can, that evidence has shown, can modify in a positive direction their experience of pain. So starting really basically with imagined movements. So if I had a patient who couldn't do any of whatever activity they wanted to do, we would have them do an imagination script of what would it look like, or what did it look like when you used to do fill in the blank, or what would it look like if you were to go home today and do that. And so creating some of that visualization techniques for them to be able to slowly start to move into that graded exposure component. Again, you all are familiar with these concepts from graded exposure and kind of other disease states as well. And there's nothing different here as it pertains to that. But they highlight some additional ways that patients can experiment. And again, I never did any of this without, talking with a primary care doctor, at least making sure that there wasn't going to be any kind of additional pieces. And most of this kind of came from the physical therapist as well. And so they suggest things like altering gravitational influences. So it may hurt to bend over, but you may be able to do a similar type of movement if you're laying on a bed. Kind of varying balance challenges, varying visual inputs has been shown to modify what the person's experience is, and the hippopotamus stepping on a nail is just one example of that. How you can think about, and you can't see it behind me here, but I have pictures of my kids and stuff on the wall. When I look at them, I have that changes the input of the rest of my experience, and so that's basically what that concept is. The environment of activities, again, are they trying to do activities with their grandkids or kids kind of running and screaming around, or are they doing it in a quiet space, potentially with some other types of positive or enjoyable things going on around them, doing it in a different emotional state. And then the last slide here they have of some additional things, adding distractions. Again, the hippopotamus is a good example of that you can remind them of. Are there ways to distract you? Not to the point where we again want to get into the worst section of the better, same, worse rule, but are there aspects of distraction that we can utilize? Planning functional activities that involve the body part. Meaning that you're going to purposely kind of create experience where the body part that's causing pain is being utilized as part of a functional activity. So again, the person can really highlight the benefits of that particular function. Breaking down functional movement. So the getting down on the floor with the grandkids. So it's and you think about it, there's actually a lot of steps to that. And so helping that particular patient think through what aspects of that might be modifiable. And the physical therapist I used to work with, we used to run a group where she would show something like getting out of bed, where she would kind of lay just on the table and show like, here's one way you can get out of bed, but if you have pain in a particular area, here's another way that you can get out of bed. And so really thinking through like the various steps of those parts impacting that. In looking through kind of performing movements with neighboring tissues in a friendly state, again, friendly being, pain-free kind of state. Experimenting with your glitches. So if there's like a particular movement that always seemed to cause problems, the physical therapist I worked with would have them just kind of experiment with that. Does that happen if you turn slightly one way or the other, or does it happen if you have something in your hand? So really creating that that inquisitive kind of mindset. Letting your mind go, which we'll spend a bit more time talking about here. But I want to transition now into this last book that they have written, which is the Protectometer or Protectometer or something. I've not ever been able to ask them how they pronounce it. But this is, as it says, is a handbook that's based off of Explain Pain, and this comes with a number of really more practical tools. It still is based on the same understanding of Explain Pain, but it has a lot more tangible pieces, and it actually has some, because it's a newer book than the Explain Pain, actually has a number of additional positive tools that I would utilize with patients. So one of them circles back to what I had said before, which is the SIMS and VIMS. Those are acronyms that they highlight, which are safeties in me and dangers in me. And so one thing that I, as part of that graded exposure, started to get people to think about is, in their lives, what are those safeties in you and the dangers in you that impact your pain experience? And I would just have them really think through the 5 different senses as it pertains to that. And in the book itself, they suggest getting like different color sticky notes and things like that. It doesn't have to be that fancy, but you really want patients to start to think about what are the things outside of the pain itself that is influencing it. Again, maybe I'm having a lot of stress with my partner and my pain is worse. Or maybe I just had a really good conversation with a friend and the pain seems to be slightly less. Maybe when I am having an enjoyable meal, it's slightly less. So really trying to think through and have them document for themselves, what are those pieces? What are those safeties in me and dangers in me? The dangers in me are just the reverse of that, kind of thinking through, are there particular things that they are interacting with that are exacerbating their pain that we, in some instances, can modify, but in some instances, it's just a matter of bringing that to their awareness so they can start to see that pain is impacted by a number of different things and is not simply, again, kind of damage equals pain equation. So I would typically have them focus in on one of the senses per appointment, depending upon the person. So are there things you do that increase pain or that are a safety? Things you say, things you think and believe, places you go, people in your life, things happening in your body, kind of those different pieces. So having them document those parts. And again, we can use those as part of the graded exposure, but we're also starting to then venture into some of the cognitive aspects of the pain experience and what we can do with those parts. As we all know, altering stress impacts our pain experience. You all are well versed on these pieces, so I'm not going to spend a lot of time talking about these, with a few exceptions. And that's has to do specifically with the kind of meditation or mindfulness pieces. And so there is a number of versions of this that I have utilized with patients that incorporate things like, and I just highlighted a couple of them here, that start to help the person see that what they see and what they think and what they're focusing on can have both a negative but also a positive impact on their pain experience. And so altered focus, just to give you one example, what I ask the patient to do would be to focus your attention on any specific non-painful part of the body. So again, an earlobe, your cheek, your hand, just it didn't matter, any part that didn't hurt, and ask them to kind of try altering the sensation in that body part. Again, thinking of it as warming, maybe as cooling, maybe a tingling sensation, maybe a tensing sensation. And for some patients that took a little bit of practice, and in some instances, I would give them kind of a handful and we would just kind of pick out ones that they seem to work better for them. So it's not like this one worked with every patient. I'm just kind of giving an example. But again, what it's starting to show them is that they can change the relationship with pain, even in something like this. Just to highlight one other one, the sensory splitting. This technique involves really kind of dividing the sensation. So patients will oftentimes talk about pain, but it's oftentimes they can say more about that. They just have gotten to the point oftentimes where they kind of say pain. But for some, it's more of a burning sensation. For some, it's like kind of a pins and needles or a tingling sensation. For some, it's a throbbing. So really trying to help them think about those parts, but then kind of seeing if they can separate them out or kind of focus in on particular parts of that experience, helping them again realize that the pain experience is complicated and that they can start to influence it, even if it's simply just kind of being able to pull those different parts apart. It's starting to create some of the self-efficacy in terms of being able, I can do something with it. For this one, it may just be, I can just pull apart how the different pains are different, but it's at least oftentimes different than how they've interacted with pain up to this point, which is really part of the key. And one of the things that I then focus in on, so we have the yeah, so Patrick's comment, not a question but a comment. I think this framework can be helpful with some current patients who live with chronic illness, arthritis, recovery from stroke, and experience ambivalence around functionality. Yes, I utilize this framework. I worked in was an internal medicine primary care clinic, and so there was a lot of chronic illness. We had an endocrinologist, so there was a lot of diabetes. It was infectious disease was co-located with us, and so there was a lot of chronic illness there as well. So absolutely, there's quite a bit of benefit that I found in working with these different populations. But so there's the psychoeducational part. There's the how do we help with the pain experience part, those kind of dual peaks, the grading exposure. Again, if they have a physical therapist or you have one you can work with as part of that, that's really fantastic as well. But it's helping them with those parts. We then start to focus in on the cognitions or the beliefs that the person has around it. And so I'll just spend a little bit of time talking about that. Can you give an example of how you use dissociation? Yeah, so that was another one that's on here as well. So how I would typically utilize it, again, all of these are patient dependent. So, if there was trauma background or reasons that I, wouldn't utilize certain ones of them, obviously we want to keep those pieces in mind. So just hopefully that makes sense. But, for a patient that seemed like a reasonable thing, I would have them imagine either the body part being separate from the rest of the body, or kind of imagining the mind and body being separated. And so one example of that would be like having their back, like if the back was the painful part, sitting in the chair across the room. And in some instances, they were able to kind of pull it as an externalized experience. For all of these, all I ever wanted them to be able to do, at least initially, not that these by themselves would kind of cure their pain experience, but to start to see that pain is something I can do something with. It doesn't have to be, and I think somebody commented on this really early on, this doesn't have to be my entire identity. This can be a part of me and may be a part of me forever. And it doesn't have to be all of me. And so how can I start to change my relationship? And so this is just one additional way that we would have people do that, to be able to say, I can separate, at least for a time being, this from the rest of my body in an experiential kind of way to, again, start to create space where they can start to make movement, both literally and figuratively in terms of the pain experience. So hopefully that helped, Karen. So in looking at the cognitive part, and just to not to return too much to data, but for me, a couple of these studies really highlight the importance of understanding the role of beliefs in what the person thinks about their pain. And catastrophizing is a really important aspect of that, as we've talked about a few different ways. But just to highlight a couple of studies. So self-perceived disability, but not pain intensity, was predictive of disability at 2 months, at 6 months, and 12 months. And other studies have shown that it goes much beyond that. So again, it's not really about pain intensity, it's about what does a person believe about what the pain has done to them or their kind of existence that is more indicative of what their actual kind of disability will be as they move forward. Psychological factors in opioid use predict disability 2 months after trauma to the bones. So again, it's not the trauma, it's the kind of psychological factors. Severity of injury and extent of injury did not predict disability at 2 months in a similar study, or at 5 to 8 months. And I, again, just highlighted a few, but there are lots and lots and lots of additional studies to this point. And this one drives it home most poignantly, which is that catastrophic thoughts were the only independent predictor of disability at 5 to 8 months. And so really focusing in on what the person believes, in addition to all the other reasons we've talked about, it may need to be something that you focus on in your therapy with the person, again, through a CBT or an ACT or alternative lens, really addressing what it is that the person believes about the experience that they're having that is most indicative of whether or not that person's going to function. And so again, it's a room of experts here in terms of CBT and ACT and other things. So I won't spend a lot of time on this, but really just to highlight from a CBT lens, listening for catastrophizing. And there is an assessment tool called the pain catastrophizing scale that can be utilized as part of this process to really help you think about, maybe I'm hearing some catastrophic thinking, but I'm not sure if that should be really a primary focus of my intervention or potentially an ancillary, or so the pain catastrophizing scale can be helpful with that. How I utilized it with patients I would really kind of explain the premise of CBT, and I won't do that for all of you because but I would explain to them, this is what CBT is and how it can be helpful. I would have them utilize thought logs as part of the process. Depending upon the patient, I would oftentimes separate out kind of the pacing and graded exposure work from the cognitive work. And that was oftentimes more because I would give the patient kind of more or less an option to kind of choose in terms of what they felt like would be most helpful for them, whether they really wanted to focus on being able to kind of do more activities, or whether or not what they were kind of thinking about seemed to impact them more. So most patients in my experience chose a kind of pacing and graded exposure as a starting point, and then we would kind of move to this. But just to again kind of highlight how I would utilize it. And it's really just kind of really basic CBT principles in terms of having them do thought logs, thought challenging. And you can really imagine the number of thoughts that a person's going to have. And I've highlighted a few of them here in terms of what the patient's experience is. Helping them do that, and then just practicing those pieces. From an ACT lens, again, there are people on this call that do a lot of ACT, and so I'm not going to spend a ton of time focusing in on this, but I would very much do the same. I would introduce the model, talking about the various principles of ACT, as you all are aware. The part that some of the earlier conversations I could tie into here was really about connecting with their values. And in some instances, that was those functional improvement kind of things. But for some, and I think Spencer had maybe commented on this in terms of their kind of existential well-being, what are some additional values that maybe are not specific to those kind of, I want to be able to do the laundry or do dishes for 5 minutes. Are there other kind of values alignment work that can be done there? And then, of course, we want to, help them kind of act in accordance with their really their values as it pertains to the pain experience. So in because again, there's lots of experts in this room, are there additional either kind of CBT or ACT tools or techniques that you all have found helpful, or maybe you haven't worked with a lot of patients with pain, but you think would be additionally helpful that I didn't highlight that you just for the group you think might be helpful? And if it doesn't fit into either of those kind of theoretical models, please offer those up as well. So Reagan's comment, relaxation exercises, a yoga practice, guided practice from which I personally benefited is not a movement practice. It is typically done lying down, but can be adapted to whatever position is most comfortable for a person, particularly in preparation for sleep and or when the nervous system is feeling overburdened. Thanks, Reagan. Yeah, Lauren commenting, really found cognitive diffusion helpful as a way to reconceptualize pain and thriving. Yeah, I couldn't agree with you more on that one. I would typically offer kind of a handout on different diffusion tactics for patients as part of this work. And they really enjoyed being able to interact with those, similar to some of the mindfulness strategies that I mentioned a couple of slides ago. Emily puts in expanding awareness from an ACT perspective and making room for pain. Awareness is closed in on the pain and breathing around to open up room for the pain and all of the other sensations. Annalise, the cactus metaphor, helpful as a way of illustrating shifting relationship to pain. So I'll also broaden it just to Reagan's kind of comment here. Are there additional techniques that people have utilized outside of ACT and CBT that you've seen a lot of benefit in working with patients with persistent pain that we want to offer up in these last couple of minutes before we open up for questions and any kind of housekeeping stuff that we need to do? So Karen's asking for some cognitive diffusion techniques, okay? Before I get to that, just other kind of tools or strategies that people have found to be helpful that you would add to really to what we've discussed today. My clients almost universally talk about the value of breathing exercises and coping with psychological and physical pain. Yeah, absolutely. And there's, as you all know, multiple ways to do breathing exercises. So I absolutely found the same thing. Oh yeah, Irina, good call out. From a Gestalt lens, you can have the person talk to the pain. And then Reagan just responding to Karen there. So, and again, there's already been some offerings here in terms of cognitive diffusion techniques. So some of the ones that I have had, and I always like choice for patients, and so I would typically kind of give them a handout of yeah, I don't remember how many were on there, but maybe 15 or so that they could try, mostly because I wanted them to at least be able to find one that hopefully they resonated with. Somebody I think had commented earlier in terms of getting people to do their homework. There was nothing, the only thing worse than that in my mind was they tried the homework and they came back and they told me it didn't help. So I always tried to give them at least enough that most of the time they would find something helpful. So, and Reagan just kind of highlighted the ACT workbook by Stephen Hayes, and yeah, there's a number of them out there. So ones that I would oftentimes just offer to patients because they could remember it really easily was something like singing what it is that they're telling themselves, or saying it in like a goofy voice or something like that. I know that there are instances where people will also kind of like put it on their screensaver and have it kind of go around and around and around like the old screensavers used to do. There's really the aspects of like kind of noticing it. Then of course, slowing things down as part of that. So kind of saying it very slowly. But it's really, at least in my mind, it's about, as the name says, diffusing or kind of creating space between you and the thought and acknowledging that the thought is just that it's something my brain is saying. It's what we then do with that information. And that's where diffusion techniques, as far as I understand them, is really just about creating that space. Annalise offered, I like to use a metaphor of fishing where thoughts or experiences are like catching fish. You can't always control what you catch, but you can control if you hang on to it or not. Absolutely. All right. Well, let me just kind of wrap up the takeaways, and then I will round back to, there was a question earlier about kind of marijuana pain experience. And then if we could just drop any additional questions in as well. I'm going to just do a takeaways slide here, and then we could open up for questions. So hopefully I did a sufficient amount of work on talking about the old model, and then really just emphasizing the limitations that existed within that model. Again, as somebody had commented, not to say that opiates are always bad or any of those parts, so not to minimize the benefits of those pieces, but there are certainly aspects of how we used to think about pain that are less helpful as we move forward. And so really thinking about what that model has looked like in the past, and again the impact that it has both on the person's pain experience, but also so many of the other things that we work with in terms of depression and anxiety, substance use disorders, all these other pieces. And so thinking about what those models, what the influence of those models is. What I would also lump into the old model is what the person has experienced as part of that model. When you look at things like substance use disorders and so forth, in many of those instances, the patients were started on those medications and have, I'm sure we've all heard stories where it then progresses from that point. And so really trying to understand what that person's experience has been as part of that model, both as it pertains to medicines, but also as it pertains to
what we have believed around surgeries and the benefits that that has, what we've believed about other pieces and what they have heard from their providers and their friends and family as part of their pain experience. In my opinion, this model really allows for better understanding of pain. I do remember what I did learn about pain before really left me kind of lacking, at least feeling like I was lacking in terms of sufficient ability to explain pain for the person in a way that felt satisfactory to me. And in many instances, as I said, clearly didn't feel satisfactory to them either, because they wouldn't come back to their second appointment. And so this model, in my experience, was able to get a lot of patients to a more functional place, but also felt to me that it did a better job of explaining how we experience pain, how pain can progress to this persistent or kind of chronic state. And most importantly, this model, as opposed to some others, really highlights that the patient can do something about it. As was highlighted earlier by one of the people in the chat, this can really get to the point where it defines a person's existence. And in some instances, it defines it entirely. And so I really wanted a patient to feel empowered through the work that we were doing around this. And so this model for me really offered that framework for them in terms of being able to actually do something about it. Hopefully, based on the evidence here, and if you'd like more, I'm happy to send more your way. But there's a lot of evidence that shows that interventions outside of medications are very helpful, and in many instances are considered the gold standard. There are, of course, as was highlighted, particular pain conditions and things like that, where the literature is either less clear or a bit more sparse, or might need to be adapted. Somebody had commented on PLS and ALS and situations like that. So it won't work for every patient with every kind of pain condition. But you could modify it in ways that you would modify other treatments for other kind of unique aspects for different patients. But keeping in mind for yourself and hopefully helping the patient to get to the space where they too believe that there are interventions that can help, and that you as a behavioral health provider can be a place to offer that as part of the work that you're doing. We spent a good chunk of time on this. Again, I shared my experience around empathy. That because of the complexities and really the biopsychosocial influences or factors that exist around us, around what it means to be in pain, and in some instances to have an invisible pain experience for some. Invisible meaning, there wasn't kind of an obvious physical thing that others could see. The impact that can have on the patient or client that comes in front of you. And the role of empathy as much, and I think it was maybe Kathy who commented about this, repairing or at least creating a space where we could still work from that person's prior experiences, whether it's with the medical community or others, and being able to move their work forward in a more positive way than they had up to that point. Remembering the pain history as part of that, focusing, as many of you commented, on functional aspects. And again, pain itself and the lessening thereof will likely be part of those functional pieces. Helping patients to think outside of the pain experience will be helpful both in terms of their ability to influence it, but will also be helpful in terms of the strategies that we talked about here, in terms of being able to get them more engaged and start to work on some of those other aspects. After we did all those pieces, we talked about really educating them about the explained pain model. And as I mentioned, the explained pain book itself is good from a clinician's perspective. It's not one that I've recommended for patients to have. The protectometer is one that I found patients related to, and again, has a lot more practical kind of tools. It's more accessible and is, at least last I checked, significantly less costly as well. But has all of the basic tenets of the explained pain book, but it's really focusing in on educating them around this model, and in many instances highlighting how it's different than maybe they've heard others talk about it, whether those are other medical providers or friends and family. And so highlighting along the way that, what they this might be different than what they have heard up to that point, and creating space for that as part of the conversation. Within that, then focusing in on those behavioral strategies, both the grading and pacing, pacing and graded exposure that we talked about, and as part of that kind of tracking mechanism, but also focusing in on those cognitive pieces that can be so important, especially when we start to look at things like catastrophizing and the person's beliefs around what we're doing with the pain experience and how that can have a really positive impact. So that really kind of summarizes it. I did just mention really briefly, and if you've not had a chance, the monitor, which I have here in front of me, has really a good article on page 54 that talks about new treatments for pain, which was a very timely article to come today or this week. But if you've not gotten a chance, they talk about some really fascinating research that's being done there. Just to summarize a couple of pieces, there was something that was kind of a very intense conglomeration of some of the things that we know to be helpful in like a 2-hour intervention that has shown to be quite remarkable. There was a virtual reality conversation in there as well. And because many of us are doing so many things virtually at this point, there was additional kind of conversation about that. But it's very much worth the read if you've not gotten a chance to look at it. So just to call people's attention to that. With that, I will open it up for additional questions. I'm hoping the person that had asked about the marijuana and pain experience, if you could maybe re-drop your question in here. Unless I can find it through the chat. You all have done a good job participating in the chat, so I'm having a hard time finding it. Insomnia techniques beyond CBTI. At least in my conversations and understanding of CBTI, and in my work with patients with insomnia, CBTI was what I used and found a lot of efficacy with it. And so I don't know if there was a particular, if there's a particular kind of challenge that you've identified. I have found a lot of efficacy with CBTI, but if there are other people that have other techniques that you've used with insomnia,
please feel free to offer them up as it pertains to this. But I have personally found CBTI to be very effective when it comes to insomnia, just more generally speaking, but with this with patients with persistent pain as well. So Janet, I don't know if you have something kind of specific you're thinking about there, or if others have other techniques. Yeah, so just kind of curiosity. And not to kind of venture too far into this space, because I admittedly am not, don't pretend to be, nor am I an expert in this space as it pertains to CBD or THC or any of those pieces. But for me, and I see your follow-up, Janet, so I'll come back to that question here in a second. But for me, it would come back to kind of, functional goals and functional improvements and potentially functional impacts on, a person's perceived benefit around CBD or THC. For example, if it was going to impact their ability to maintain employment, if it was maintain their ability to have, I know some providers practice with rules in their own mind, or not their own minds, but like as part of their practice, that if a patient is using marijuana, that they will not prescribe opiates. So those would need to be considerations for patients as part of that process. But I've had patients who experience it to be helpful. I've had some who've tried it and didn't experience it to be helpful. So it kind of varies in my experience based on what patients have seen or experienced themselves. And for me, I really wanted them to at least have for us to have a good understanding of potential functional improvements or functional impacts, or their ability, again, to maintain employment or have the primary care doctor they wanted to have, or, kind of other things that marijuana use or CBD use they might want to consider as part of that process. Janet, so just rounding back to your insomnia question in terms of, I find people using good sleep hygiene, but pain keeping them awake. And that's where, for me, sleep hygiene, of course, being a component of CBTI, but really helping people focus in on other aspects of the CBTI model, whether it's restricting their exposure to bed when they can't sleep, limiting their kind of napping and all those pieces outside of that. For a lot of the patients that's where they would utilize some of their opiates, was around sleep or things like that, and felt like that was helpful. For some, they would use heating pads or things like that. So we would oftentimes take an experimental mindset when it came to sleep. In my experience, patients with pain and insomnia had a lot of, in my mind, very understandable frustrations. And so there was also a lot of beliefs and a lot of kind of catastrophizing around that. And so depending upon the person, I may focus more in on creating a sleep schedule and potentially educating them on some sleep hygiene pieces. For others, it was more around experimenting with positional kind of parts, moving pillows around or those types of things. And in some instances, it was working on some of those other kind of tools or techniques that they found to be helpful as part of their process. All right. Well, I don't think I missed any questions, but if there are more, feel free to drop them in. Otherwise, or Jeff,
don't know if I'm assuming there's some kind of closing messaging we want to offer for people, and hopefully I timed it well enough so they can still get out of here on time.
Perfect.
Oh, one more question here. To what extent do you think treatment for pain is similar to physical therapy and weighs heavily on follow through with homework between sessions? Just have to think about your question here for a second. I'm not sure I'm tracking exactly your question, but I oftentimes had patients who had tried physical therapy and for a number of reasons did not find it beneficial. I had some who found it beneficial, and I had some who didn't give it probably enough of a try to see the benefits. And so for me, mindset was such an important part of perceived benefit or not. And and hopefully I've made clear today, that mindset as it pertains to this work is an imperative part, both in having them know that you believe their pain experience is what they are experiencing, but that we can still do something with that. And that's where those are perhaps some of the similarities and differences I see in that it comes down to mindset. Those that saw benefit, and again, I had the luxury of working a couple of days a week with the physical therapist, or at least they were working in the clinic with me. And by and large, those that did well in my environment also did well with her. And a lot of it came down to mindset, kind of what the person believed about what their experience was telling them. And then it impacted their willingness to follow through on homework and come back to sessions and things like that. So hopefully that got close to your question, Arthur. Feel free to ask a clarifying one if I missed the mark there.
Okay.
All right. Awesome. Well, thank you all for joining me on a Friday morning, and for being really engaged as best as we can do in a virtual environment. If at any point I can be helpful in the future, I think my contact information is, you can contact me through the OPA website, and I'm happy to drop in my information here, but you can see me on Providence websites and so forth. And I know many of you, so I'll probably see you around at various other things. But thank you all for having me here this morning. It was really enjoyable to get a chance to talk to you all. And Linda and Jeff, I'll hand it over to you to do all the administrative stuff.
Thank you again to everyone for joining us, and a big thanks to you, Ryan, for making time to do this for the OPA membership. So I see questions about slides. You will be getting the slides. A survey will be sent to you shortly, and one of the questions will be asking you for the presentation code so that you can receive CE credit. So that code is OPA 0822. And I hope you enjoy the rest of your day. Anything else from Jeff?
I'm good.
Okay, thank you again.